is wonderful. Always it's a learning experience to speak, to listen to Sir. So with this, I will go on to my talk, which is on acute demyelinating syndromes and diseases. Yeah, can I have it in slide mode, please? So coming to the introduction, this will be part of a little part of the presentation will be a repetition of what Dr. Udani said, but in this we will be talking more in detail, a little more basic a review of the concepts. So our basics are a little brushed up. So coming to the introduction, acute demyelinating syndromes are a group of neuroimmune disorders, and in them there is a breakdown of myelin sheath, as the name suggests. It is usually sudden in onset, but it could also have a protracted course. Some children, and they usually present with neurological symptoms with typical neuroimaging findings suggestive of demyelination. So talking about the outcomes, usually they could be varied from full recovery, especially in more positive cases and in ADEM children, to severe disability, not only neuro disability in form of motor disability, but also neurocognitive deficits can be seen. We do see these children on follow-up, though they've recovered totally on neurological basis. They may have certain behavioral changes, a little irritability, a little behavioral changes in terms of ADHD, etc. So again, going ahead to how we can characterize these syndromes, it can be divided into two types based on the location and frequency of the demyelination events. So can I have the next slide? Yeah, monophasic events can be classified as clinically isolated syndrome, and they are usually characterized by monofocal or polyfocal deficits without encephalopathy. ADEM is characterized by polyfocal deficits with encephalopathy. Yeah, this was the previous slide which I missed on, sorry. So depending on the location, we can have focal or multifocal in location. ADEM is usually a multifocal kind of disease. MOGAD can come as multifocal, or an MO is again a multifocal disease. Then you have focal diseases can present with only transverse myelitis or transverse myelitis as a part of a syndrome, optic neuritis, again alone isolated, or part of a syndrome, multiple sclerosis and clinically isolated syndrome. So this is generally the overview or what we would call as part of the spectrum of ADS. If time permitting, we'll see how much we can discuss today, and otherwise we have a brief review of the same. So coming to the ADEM criteria, now these diagnostic criteria were updated by the IPMSG, which stands for International Pediatric Multiple Sclerosis Study Group, in 2013. The definition is first polyfocal clinical event with presumed inflammatory demyelinating cause. Presence of an encephalopathy is mandatory. Encephalopathy has been defined as an alteration in consciousness of behavior unexplained by the fever, concurrent fever, which would be there, systemic illnesses or post-ictal symptoms. A brain MRI consisting with a demyelination, especially during the acute phase. Up to 3 months is what is the acute phase defined as, and no new symptoms, signs, or MRI findings 3 months after the incident ADEM. So coming to more like algorithm, so you have children who present with encephalopathy at the first event or without encephalopathy. As we discussed, polyfocal without encephalopathy would be a CIS. With encephalopathy is definitely called as an ADEM. And if there is recurrence of signs and symptoms within 3 months, it is considered as the same episode of ADEM. But after beyond 3 months of the event, then it is considered as a multiphasic or a recurrent ADEM. And any further symptoms, again, in those cases can be considered as a chronic relapsing disorder, MS, etc. has to be definitely thought of in these cases. Coming to the epidemiology, usually we see in children less than 10 years, the median age is 6 years. Males, again, predominance is present. prior to earlier, we have case reports in the 80s and 90s about post-immunization edema, especially within, say, 4 weeks, 3 to 4 weeks of receiving immunization, primary immunization. But nowadays, we see these cases on a more lower spectrum, and often we have a prodrome of either respiratory infections or acute gastrointestinal infections as a prodromal feature. Now, coming to the clinical presentation, again, as we said, that encephalopathy is mandatory. Usually, they have an acute onset of encephalopathy with polyfocal neurological symptoms, depending on where the demyelination occurs. The usual time for maximum deficits is about 4.5 days or 5 days. Definitely within a week, the progression and the nadar comes in. And encephalopathy can be varying in forms of lethargy to irritability to drowsiness to absolute coma. Usually, these children present with pyramidal signs or are present. They can present with ataxia. They can present with hemiparesis, which is again a very common mode of presentation. Cranial deficits, optic neuritis as a polyfocal feature, spinal cord in terms of transverse myelitis presenting as a polyfocal feature, impairment in speech, seizures again, but more so in the younger lot and often focal motor seizures. They can come catastrophically and present in the ICU instead of the OPD or the casualty, almost in 15% of the cases. So what do? We have the entire algorithm, and as always, it begins with a detailed clinical history and a detailed neuro exam. We also have to do a lumbar puncture to rule out OCBs. OCBs are oligoclonal bands, which are 80% to 90% seen in MS cases. We, of course, do an MRI, plain and contrast, to see for post-contrast enhancement, the brain, spine, and orbital cuts. In addition to what Sir also mentioned, I would like to emphasize that we have to do serum studies for antibodies of MOG antibodies and aquaporin 4 antibodies. And here we always do a cellular-based assays. Now, coming to the MRI findings, we usually see these multiple large, fluffy, ill-defined lesions. They're usually bilateral in location, hyperintense lesions on the T2 and flare, and can be involving the subcortical and central white matter, the cerebellum, the brainstem, the thalami, the basal ganglia, and spinal cord also. What we also see in all these cases is a contrast enhancement. Now, coming to the possible DDs based on the clinical features, if a child presents with, in addition to ADEM, if the child has, clinically we are suspecting ADEM, but the child has a persistent meningeal signs or headaches, then we also should rule out an infectious cause of encephalitis and CNS vasculitis, stroke-like event. We think of mitochondrial diseases or any other structural malformations. Recurrent seizures, we think of infections or autoimmune encephalitis, a progressive course and history of developmental delay underlying. We should always think of a genetic or a metabolic cause. And a higher cell count can also, we have to look out for a CNS infection. Now, based on MRI or imaging findings, if we see diffuse symmetric lesions, they can see like a leukoencephalopathy, like white matter changes, we think of leukodystrophies, etc. If there is ischemia with restricted diffusion, one should think of strokes, MELAs, and if there's mesial temporal lesions, especially in a child who's presenting with autoimmune encephalitis, one should think of an MDR encephalitis too. Now, the treatment in all demyelinating conditions remain the same. There is, of course, the gold standard is steroids. Usually, most of the children have received a high dose of steroid when they come to us, or that is the first line of treatment that we offer here, MBS 30 milligram per kg per day over 4 to 5 days. And if the course is progressing or the response is not too good, then we do give IVIG 2 gram per kg depending on the affordability and the availability. And PLEX is also a suggested form of therapy for the resistant cases. There is some school of thought that post MBS oral steroids can be given on a smaller dose of 1 to 2 milligram per kg per day and taper over 4 to 6 weeks. Now, coming to the outcomes, there are usually good outcomes with treatment and full recovery with complete resolution in almost 57 to 92% of the cases. And I'm talking about resolution of the MRI lesions. If the improvement and when it begins, it is usually by the end of the first week, because remember we said that the progression of the symptoms can occur in the first week, and definitely a full recovery by 1 month. There exists some common sequelae like focal motor deficits in 17%, and as I earlier said that some behavioral outcomes, therefore neuropsych evaluation is required. Lower IQs are known, and this can affect the educational profile. Recurrence risk in ADEM is 10 to 30% and usually happens within the first 2 years of the event, the first event. So this is necessary to explain to the parents the reason for a follow-up, and even to prognosticate, etc., or help some counseling the parents. The MDEM risk is higher if there is associated optic neuritis in the first event, or there is a family history of other neuroimmune diseases in the family. So it is recommended that we do a MRI screening every quarterly, every 3 monthly, up to at least the first year post-demyelination event. Coming to the first case, so we have a 9-year-old. We had a 9-year-old male child who came to our OPD with headache and vomiting acutely since the last 1 day with altered sensorium, 1 episode of a GTC convulsion. 1 week ago, the child was treated for tonsillitis with antibiotics. On examination, he was awake but drowsy. He had signs of meningeal irritability. He had a left lateral rectus palsy, some mild increased tone plus minus. Prover was okay, but the reflexes were definitely present. So some pyramidal signs were definitely present. On investigations, there was leukocytosis. On the peripheral smear, some atypical lymphocytes were present, and this child was investigated in private, and serum EBV was found to be positive. When he came to us, we did CSF. CSF was within normal, no OCB's presence. Serum anti-MOG antibodies were positive, and his MRI, of course, was the one which reached the diagnosis, which showed diffuse hyperintensity in the left frontal cortex, etc., and some viral edema can be seen. Now coming to MOG associated diseases, MOG stands for myelin oligodendrocyte antibodies diseases. So this is an antibody-mediated inflammatory demyelinating disorder, the CNS. There are various phenotypes of MOGAD. One can be the demyelinating, which we saw, which has a commonly ADEM kind of presentation, and in them MOG antibodies has to be done to know about the prognosis and the later outcomes. And again, the second type is the encephalitis kind of a presentation. So just overviewing, again, it can present like an ADEM with or without optic neuritis, or pure optic neuritis, again with or without transverse myelitis, or just transverse myelitis, and a non-ADEM kind of encephalitis. So where is MOG exactly present? MOG is a glycoprotein. It's present on the myelin within the CNS, and in fact, the MOG expression begins with myelination, and it is an indication of the oligodendrocyte maturation. So coming to the presentation, we said ADEM is the most common presentation in younger children. Antibodies can be present in almost 40 to 68% of these cases. However, if the presentation of encephalopathy is more emotional or behavioral kind of symptoms, then the likelihood of ADEM or MOG being present in them is less likely, 5% versus 43%. And pure monophasic ADEM is seen in 83% of the presentation in MOGAD. The good thing is that there is almost a complete good recovery in these children. And of course, if there is a recurrent or a MDM kind of presentation or encephalitis and they present with MOGAD positivity, then the outcome is not too good. As I said, they can present with optic neuritis, and we know the classical presentation of optic neuritis is eye pain, vision loss, etc. Transverse myelitis could be a level, and they can present with acute classic paralysis, especially if the conus medullaris is involved. And they usually present with a longitudinal extensive transverse myelitis. That means more than 3 adjacent vertebral segment is involved, usually in the cervical, thoracic, or in the lumbar region. Now coming to non-ADEM kind of encephalitis presentation, they present with seizures, which is a very defining kind of a presentation, altered sensorium, behavior, motor deficits, movements. And in these children, 62% of they could be MOG antibody positive. So so it's necessary to do a serum mock along with the encephalitis panel that we usually send of NMDAR. And especially it is seen that if these children have MRI features suggestive of bilateral cortical encephalitis and a basal ganglion involvement, then in some of them the outcome can be poor with cortical atrophy and refractory epilepsy. So coming to the MOGAD proposed criteria, the disease is confirmed if these three criteria are met with the clinical picture that we discussed with, in which edema presentation is the most commonest. Neuroimaging findings of demyelination. If this child presents with optic neuritis, then VEP, etc., is mandatory to be done. And of course, the presence and positivity of MOG autoantibodies, which is positive on a cell-based assay. And definitely it can be done during the presentation and during the acute presentation. So within 3 months, definitely the antibodies can become negative after a year of the demyelination event. And in case there are higher level of antibodies, then it suggests that the relapses would be more common in that particular case. And in a case of CIS without encephalopathy, then it is a good predictor for multiple sclerosis. However, a word of caution: if the aquaporin P4 also antibodies are positive and MOG is positive, then definitely this is considered erroneous and it requires retesting. Now, treatment, as I said, for most of the demyelination events is the same: MPS, IVIG, or PLEX, and the outcomes depend on whether it is relapsing kind of a MOGAD. If it's relapsing, then disability is more common in them, and more often than not, if there are higher levels of anti-MOG and it is a relapsing kind of a course of and persistent seropositivity, one may need to continue with either rituximab or repeated cycle of IVIG. Now, to summarize, anti-MOG antibody positivity indicates a demyelination event in pediatrics distinct from multiple sclerosis. It is necessary to check for anti-MOG antibodies in demyelination or cases of non-edem kind of encephalopathy, and prognosis is usually good. Always remember to do a serum-based analysis or a cell-based assay for MOG antibodies. Do I have the time? Can I continue? Yes. So continuing with this case, again, a 5-year-old born of non-consanguineous marriage came to our casualty with headaches since 20 days, fever since 18 days, irritability since 16 days, and left limb neuroparesis. On examination, the child was drowsy, irritable, no cranial nerve deficits. A mild hypotonia and oligolimps was present. However, the reflexes were brisk. And we thought of acute febrile encephalopathy with some motor deficits. When we investigated this child, we found that the CSF, there were only 10 cells, and proteins was definitely elevated, sugars were normal. So we did the MRI, and the MRI was showed demyelination event, and the serum MOG antibodies were positive in this event. So here you can see the MRI findings, and now we move on to NMO, spectrum disorders. If we have the time, we can continue or okay. So neuromyelitis optica spectrum disorders are a demyelinating astropathy, and it usually affects the optic nerve, the spinal cord, but also certain regions of the CNS. And typically, these attacks are quite severe with poor recovery, and they lead to long-term disability. More common in females, also because the aquaporin is expressed in various parts of the body. You could have a coexisting systemic autoimmune disease like SLE, myasthenia gravis, and celiac disease. Now, coming to the clinical features, the attacks are usually severe in nature, and within 7 days, the whole presentation evolves. Again, they present, as the name suggests, with a transverse myelitis, which is longitudinal, extensive, of more than 3 contiguous vertebral segments, and usually involving the central gray matter area. So these children present with paraplegia, tetraplegia, depending on the level of where the lesion is present. They can come with a sensory symptoms of intense itching and sometimes tonic spasm. Bladder involvement is often present. If they come with optic neuritis, it's usually bilateral in onset. it could be longitudinal, and definitely there's a predilection for a posterior optic nerve segments or optic chiasma is usually involved in this. Now coming to the CNS presentation, they can present with the post-trema syndrome, which is basically a secondary inflammation in the emetic reflex center. So they come with intractable nausea, vomiting, or hiccups. And this could be a presenting feature in 10 to 12% of pediatric patients. We have not seen any such case to date. Acute brainstem syndromes can also be the presenting feature. If they present with certain CNS findings also, like encephalopathy, or they can present with paresis, seizures in 60%, and more often you have demyelinating lesions in the brain, but they are usually clinically silent. So coming on to the tests which are done and the treatment which is there for MMO, of course, for any given thing, the clinical exam is first, neuroimaging which has to be done, and see them aquaporin 4 antibodies have to be done. It's not uncommon to get it negative, but if you're strongly suspecting, then one should repeat it again at 3 months later. Now, these aquaporin 4 antibodies are usually present, or the protein is present in the water channel in the brain, cord, and optic nerves, and that kind of, tells us why the location of involvement. It's usually periaqueductal or around the where the water channels are present. So treatment again remains the same. It is NPS, which is given which is given as an acute during the acute event, followed by oral steroids, and which are given for about 4 to 6 weeks, and we gradually taper it over 3 to 6 weeks. Now concluding the presentation, we know that acute demyelinating syndromes are a group of neuroimmune demyelinating disorders, and ADEM has a strong predilection in young children. ADEM is the most commonest of them, and it can be whether it is the first presenting symptoms for MS, it is debatable. The role of autoantibodies, the newer ones especially, and this is undebatable. One has to do an MO or more, and the presence of them and the positivity test and them has definitely enhanced our understanding of these diseases. The spectrum of MOGAD is wider than thought. Earlier, we used to think it was present only in demyelinating events, but we now know that they can present with encephalitic syndromes also. Thank you for a patient hearing, and I hand over to Aditi to let me know if there are any questions in the chat box.
Thank you so much, ma'am. Dear delegates, you can post your questions in the chat box. Meanwhile, we have a couple of questions. Ma'am, the first question is, should all demyelination disorders be worked up for MOG antibody?
Yes. So yes, when the availability is there, or financial availability is there, especially because it generally gives you a picture that that the outcomes would be good. If again, as I said, if the antibodies are too high, then it can also suggest a relapsing kind of process. So I would definitely recommend if one does antibodies. Yes.
Neuroimaging. The second question is there any role of repeat neuroimaging?
Yeah. So as we said, that when we follow up these children up to 3 months, sometimes the lesions can be seen on the MRI. But usually by 3 months, first 3 months is what is defined as a first event, or the first event can last up to 3 months. Okay, so the MRI can be positive up to 3 months after the initial presentation, and beyond 3 months, you expect the resolution of the symptoms in terms of the MRI. This is especially important that if the child comes later on with symptoms, one has to define whether this was an endem or is a continuation of the same event. So the cutoff has been given as 3 months. So definitely it is recommended that MRI screening be done in these cases every quarterly, especially for the first year, because see, the relapses can occur up to the first 2 years is a common time for relapses to occur.
Okay. Thank you so much, ma'am. Since there are no questions in the chat box, I think we may conclude the session. Thank you so much, ma'am.
Thank you so much for the organizing team of DAFPAL and Department of Pediatrics and executive team of DAFPAL for having this wonderful team for today's presentation, and thank you everyone.
Thank you, ma'am. Our next session is by Dr. Arpita Adhikari ma'am, Associate Professor, Division of Pediatric Neurology and Epilepsy under Department of Pediatrics at LTMGH. Her areas of interest are pediatric epilepsy, neurometabolic disorders, and neurodevelopmental disorders. Ma'am will be talking on approach to seizures in children. Over to you, ma'am.
Good morning, everyone. At the outset, I thank the organizers for giving me the opportunity to share my experience on the approach to epilepsy in children. So the outline of my talk would include a stepwise approach to childhood epilepsy. We would be looking at some definitions and terminologies, the ILA 2017 classification, seizure types with cases and videos, childhood epilepsy syndromes, approach with an algorithm, cases and videos, and role of EEG and neuroimaging in epilepsy. So epilepsy is a common pediatric neurological problem with an incidence which is 5% of 1,000 population. It constitutes 70% of all pediatric neurological problems. 70% of epilepsies have onset in the pediatric age group. It causes a deleterious effect on the developing brain, leading to a significant psychosocial and economic burden. It's a very much treatable neurological problem, and hence a judicious approach will lead to early diagnosis and management, which will prevent significant morbidity. So a stepwise approach, what do we need to know when we get a child with seizure? First of all, whether is it a seizure? So we need to differentiate seizure versus other paroxysmal events. What is the seizure type? It's very important to listen to the description by the parent or observer. Is it provoked? So provoked versus unprovoked seizure. What is the syndrome type? We need to classify the syndrome with EEG and other relevant history. So now, first to know whether it is a seizure, we need to know what is epilepsy and what are non-epileptic events. Non-epileptic events can be psychogenic or physiologic. Physiologic non-epileptic events are more common in infancy and childhood. EEG may be of help, but it is not always decisive to differentiate in between the two. EEG can be normal in 30 to 50% of epileptic children, and also epileptiform activity can be seen in some normal children. So it is not a dictum that if you get EEG abnormal, it is an epileptic event. A possibility of non-epileptic event should also be considered in epileptic children with refractory seizures and multiple seizure types. Going to some definition and terminologies. So epilepsy is a condition characterized by recurrent, 2 or more unprovoked or reflex seizures that are occurring more than 24 hours apart. It also includes one unprovoked or reflex seizure and the probability of general recurrence risk occurring over the next 10 years. Epilepsy syndrome is a complex of signs and symptoms that defines a unique epilepsy condition. And epileptic encephalopathy are the epileptiform abnormalities in the EEG which contribute to progressive disturbance of cerebral function. A single seizure, this is very important, a single seizure does not constitute epilepsy, and 2 initial seizures occurring within a 24-hour period carry the same significance as a single seizure. So please remember that when you need to call someone as epilepsy, there have to be more seizures. The duration in between the 2 seizures has to be at least 24 hours apart. Now let's look at some basics of the phases of seizure. So there can be a prodrome, that's a pre-ictal phenomenon. It's subjective or objective and it just heralds the onset of an epileptic seizure, but it's not a part of it. Aura, it's a part of a seizure. It gives us a lot of localization value. It is a subjective ictal phenomenon and it precedes the seizure. ICES defines aura as a part of the seizure which occurs before the consciousness is lost and the child can retain the memory afterwards. Now, aura can be of many types. It can be a sensory aura like tingling numbness, a visceral aura like epigastric sensations, psychic, somatosensory. Although children won't be able to describe the aura in details, they might say that something is happening inside or something funny. It is important to know this because you are able to have a localization value. Ictal period is when there is manifestation of clinical and EEG changes that are associated with the neuronal firing. Post-ictal is time when the neurons have stopped firing. Automatisms, this is extremely important. It is a more or less coordinated, repetitive motor activity usually occurring when the cognition is impaired and for which the subject is amnesic afterwards. So aura, a subject can remember, but automatism is where the subject does not remember what the subject had done. This often resembles a voluntary movement and it may consist of some ongoing pre-ictal motor activity. I'm going to show some videos regarding that. Now, automatisms can be simple. It can be oro-alimentary in the form of lip smacking, chewing, vocal grunts, verbal shouting, talking. Child might have fumbling, fiddling, ambulatory, walking in circles, manual and mimetic. Complex automatisms in the form of chewing inedible objects or wandering. Now, what are the points? These are extremely important. When taken a good history, you can definitely differentiate whether it is a seizure or a non-epileptic event. So the most important is history from the person who witnessed the seizure. So please do take a history from the person who has witnessed the seizure, be it one-on-one, or if the person is not present, then over a phone call. What was the time of onset of seizure is equally important. There are certain seizures which are nocturnal, like a frontal lobe seizure or benign Hollandic epilepsy. What was the child doing at the time of onset? So you need to describe the seizure in details. Was there any aura present? Because as I said, the aura always gives a localization value. Did the child report any funny feeling, a visual image, fear, or an epigastric sensation? Then an entire description of the seizure. Where did it start? How did it progress? What was the type? Was there any deviation? What was the position of the eyes at onset? Check for responsiveness, whether the child is altered or he is not. And was there any involuntary passage of stool or urine? That just indicates whether it is a generalized seizure. Although this is basic, but this is extremely important because when you take a good history, on the history itself, you would be able to differentiate whether it is an epileptic or a non-epileptic event, and history needs to be taken in a systematic manner. How long did the seizure last? What was the post-ictal condition of the child? In the left-hand side history, the most important is the birth and development, because once you know the birth and development is normal, there is a separate algorithm to know the epilepsy syndromes. In a child with delayed birth and development, the algorithm is separate. Family history of epilepsy tells us about the prognosis. In examination, there are certain markers. You need to take a head circumference. Neurocutaneous markers are extremely important. So these are some of the neurocutaneous markers that you should look at in any child with epilepsy. Caffiole spots, you can see the Ashleaf macules. This is the Sturge-Weber syndrome. So what are the hallmarks of seizure? In a seizure, there has to be alteration of awareness or behavioral arrest. They are absolutely stereotypic. If the parent has seen the first seizure, the parent will be able to say whether the next seizure when it's coming. So they are very, very stereotypic. They are recurrent. They might occur on fixed time of the day. As regards to some seizures, there would be preceding symptoms like aura, headache, irritability, following symptoms such as headache, drowsiness, and vomiting. So these hallmarks are again important to know whether it's a seizure or a non-epileptic event. So now let's look at the ILAE 2017 classification. This is the basic version where ILAE classifies into focal onset. Focal onset is further divided into whether it is awareness preserved or impaired awareness. Generalized onset, whether it is a motor seizure or non-motor seizure, and unknown onset when the onset is not seen. So this is the detailed classification. Focal onset with awareness preserved and awareness impaired, which can be further looked at whether it is motor whether it is atonic, clonic, epileptic spasms, or it is non-motor in the form of just behavioral arrest, cognitive or emotional imbalance. Generalized onset further classified into motor. Motor could be a tonic-clonic, clonic-tonic, myoclonic, myoclonic-atonic. Non-motor are your absence seizures. So this is the schema that you need to do for epilepsy. First, you need to know the seizure type, whether it is focal, generalized, unknown. Then you need to know the epilepsy type, focal, generalized, combined generalized, and focal. Then along with the EEG pattern and the history and prognosis, there are various epilepsy syndromes. Also, the investigations helps in knowing the etiology, whether it is structural, genetic, infectious, metabolic, immune or unknown, and also the comorbidity. So these are the schema that one needs to know when you are dealing with a child with epilepsy. So now let me take you through some seizure types with cases and videos. Let's look at the first seizure type, focal onset with impaired awareness. The clinical manifestations will vary with the site of origin, as I already described. The different type of auras will give you the localization value. Most commonly, 60% of these focal seizures arise from the temporal lobe. You need to know the presence and the nature of aura automatisms. Duration is typically less than 2 minutes. So this is a 10-year-old boy. While he was asleep, he had sudden onset bipedal
Rugan, hey, Rugan, Rugan,
and after this, the child was
Rugan.
This is a 2-year-old boy. If you can just see, he is just playing with a dummy fruit and there is a dummy knife in his hand. There is a confusion. He is having some lip smacking, which is lasting for around a minute. Looking very confused. He's lip smacking, although it is just looking that there is an ongoing, whatever he was doing earlier, he is just following that. Yeah? And just after this, there was a post-ictal drowsiness for half an hour. So what the first child we saw was a frontal lobe seizure. In frontal lobe seizures, they are frequent. They are mainly in sleep. They are very abrupt and explosive. The progression is very rapid. As you saw, there was bipedal automatisms. Early, frequent, prominent posturing was present. Hyperkinetic motor signs were there. The seizure duration was very brief. There could be grunting, screaming, moaning also present. Secondary generalization is very common in frontal lobe seizures, and the post-ictal confusion is less prominent and short. The second child we saw was a temporal lobe seizure, in which they have a motionless staring. There is automatisms, as I already described. It could be a simple or a complex automatism. The seizure duration is slightly longer, and the post-ictal confusion is more prominent and longer. Now let's go to the generalized onset seizures. In generalized onset, the motor seizures, which I told, the tonic, clonic, tonic and myoclonic, and non-motor, that is the absence. So this is an 8-year-old girl who is birth and developmentally normal, and she has got decreased school performance, and she was daydreaming. So she came to us in the OPD. So this is a very important test in the OPD that you do on any child who comes with such history that there is a decrease in the school grades, the child is just daydreaming, the teacher is complaining that for a while the teacher doesn't come to know what the child is doing, and then the child is back to normal. So this is the hyperventilation test. You just take a piece of paper, tell the child to blow. You need to do vigorous breathing in and breathing out for almost 3 minutes or so. And if you can make the child count, then you come to know if it's not equal to hyperventilation means for the window of the room. See that? Now going down to her eyes. Yeah, yeah. Just lifting her eyes. And just now completely cut.
ठीक है ना नाव काय
This is a 6-year-old boy, birth and development normal. Again, he came with a history of inattentiveness in school and poor grades for the last 3 months. He was not cooperative for a hyperventilation test in the OPD, and he couldn't, do that vigorous thing. So we did the hyperventilation test as an EEG activation process.
बहुत
So you
अच्छी
see the technician is giving him instruction that he needs to breathe in, breathe out.
करते रहो लंबी सांस अंदर लो छोड़ो वेरी गुड सिर नहीं हिलना चाहिए बेटा
So
करते रहो
he is just hyperventilating. See that again he is having blinking of the eye.
यहाँ देखो हाथ की तरफ देखो
Lip smack, he is not at all responsive. Yeah.
बहुत अच्छी
So this is the EEG which is showing a typical 3 Hz spike and wave that we got in him when he was having this episode of repetitive eye blinking. So what is childhood absence seizures? These are brief staring spells with impairment of awareness. 3 to 20 seconds. They would be sudden onset and sudden resolution. As it is a generalized seizure, there is no aura. Neither there is no post-ictal confusion as they are very short lasting. There is no loss of postural control or any significant motor activity. In both the children, you saw that repetitive eye blinking is the most common thing, and there could be some facial automatisms in the form of lip smacking. This is often provoked by hyperventilation and photic stimulation. These are EEG activation procedures. So any child who comes to the OPD and is referred for decreased scholastic performance with a classical history that the child is a daydreamer, do this simple test of hyperventilation, which will give you enough clue about absence seizures, because these seizures, when treated early, they really respond well. The onset is typically between 4 to 14 years of age. They often resolve by 18. They are normal development and intelligence. And the EEG is a classical 3 Hz cycle per second. You see in 1 second there is 3 Hz spike and wave pattern. As AEDs, valproate, ethosuximide followed by benzodiazepine and lamotrigine are the drugs of choice. Treatment should be continued for a minimum seizure-free period of 2 years with a normal EEG at discontinuation. EEG may be repeated after 6 to 8 weeks of tapering the AEDs to look for reappearance of any spike wave discharges. Now there's something called as an atypical absence seizure, which is less abrupt in onset and cessation. Lapse of consciousness is usually longer. In atypical absence, you might get some minor myoclonic movements of the face. And the EEG is not classical. It has got a frequency of 2.5 seconds or less. The most common differentiation is how do you differentiate absence from focal motor seizures with impaired awareness. So just note out here, in focal motor seizures with impaired awareness, as we saw earlier, they are like longer. There is always a motor activity. So in absence seizure, there is no motor activity. There is just eye blinking and facial automatisms. Whereas saw the frontal lobe and the temporal lobe seizures, which both had some motor activity. And they show some post-ictal impairment in focal motor seizures with impaired awareness. So now coming to myoclonic seizure. What is a myoclonic seizure? It's a brief shock-like jerk of a muscle or group of muscles. You need to know whether it is a physiologic myoclonus or an epileptic myoclonus. It is typically bilateral, synchronous. Impairment of consciousness is very difficult to assess because they are short-lasting seizures, less than 1 second. They can evolve into rhythmic jerking movements, clonic seizures. You need to differentiate from benign non-epileptic myoclonus while falling asleep. And EEG is characteristic by 4 to 6 Hz polyspike wave discharges. So this is a 7-year-old boy, birth and development normal. He had measles at 9 months of age, and now he comes to us with deterioration in cognition.
खड़ा करो. बिठा दे अभी.
So this is another boy, a 10-year-old boy. He is also birth and developmentally normal. He has also brief jerks of both upper limbs and the head. You see.
Visa, like using appropriate doctor suggestions morning.
Upper limbs and head jerk.
Hippocampal degeneration comes from where? What are the reasons?
So it's very important for you to see these myoclonic jerks. They are very subtle, they are very brief. So it is important to take a video if the parent is complaining of something. Video is the best. Always for a myoclonic jerk, see to it that the child is in an anti-gravity position, either sitting, because if the jerks are very mild in the lying down position, you might miss it. Although in this child, we could catch the jerks. This was the EEG in the child which showed the burst suppression pattern, and this is typical of SSP. Now the step 2, after knowing whether it is a seizure or no, then knowing what is the seizure type. As we said, classified into focal onset with impaired awareness and aware generalized seizure. We need to know whether it is a provoked seizure or an unprovoked seizure. So if you remember, the definition of epilepsy was unprovoked seizure. So whenever a child is having a provoked seizure, we need to look at the provocation factors, whether it is a febrile seizure, whether there are electrolyte imbalances such as hypocalcemia, hypoglycemia, infections such as meningitis, encephalitis. Unprovoked seizure, there is no reason for provoking, and it is sudden in onset. So an unprovoked seizure, 2 or more seizures more than 24 hours apart, goes in favor of epilepsy. Now going to the childhood epilepsy syndromes, I just take you through some algorithms, although it's not possible to cover everything in details. So why do we call it as a childhood epileptic syndrome? An epilepsy syndrome is something when you group a patient that share a similar seizure type, the age of onset is similar, there is a natural history and prognosis, the EEG patterns are prototype, genetics is involved, and response to treatment is there. So when there is a conglomerate of all these, then you call it as a childhood epileptic syndrome. So ILA classifies in 2017 the childhood epileptic syndrome are the benign or the self-limited ones and the pharmacoresponsive epilepsy syndromes. And the second classification is epileptic encephalopathies, which I said that is the epileptiform abnormalities themselves contribute to the progressive disturbance of cerebral function. This is extremely important to know because it is a devastating encephalopathy. So going to some algorithms, this is a neonate, in neonates 0 to 2 months. Always, as I told, look at the neurodevelopment, the birth and development history. When the birth and development history is normal, a neonate comes to you, ask for the seizure type. If the seizure type is a clonic seizure type, then look for the family history. If the family history is positive, then it is benign neonatal familial convulsions. So these are the convulsion that comes in a healthy term baby in the first week of life, where there is a positive family history. This is a channelopathy, KCNQ2 mutation, and the EEG will be normal or just mildly abnormal spike and sharp waves will be seen. There is no need of any AEDs as the prognosis is very good and they remit themselves in first 1 to 6 months of age. Now again, a child with normal development with clonic seizures in the neonatal period, no family history. The family history is negative, but the seizures are clonic. It could be benign idiopathic neonatal seizures. Again, this come in term healthy babies. EEG has a classical variable theta 0.2 alternate. There is no need of any AEDs as it has good prognosis and it remits by itself. Now, neonate 0 to 2 months of age, when the birth and development is abnormal, then you again look at the seizure type. When the seizure type is tonic spasms, As I told you, we need to look at the epileptic encephalopathy. So this is early infantile epileptic encephalopathy or the Athavale syndrome. And when the seizure type is fragmentary myoclonus, then it is early myoclonic encephalopathy. So these are very important to pick up at an early age, because if given treatment early, then the comorbidities or the morbidities are less. So just to differentiate in between the two, Athavale is predominant tonic spasms, which occur both in sleep and wakeful state. They can present right from intrauterine to 3 months of age. EEG is again classical. There is continuous suppression burst pattern both in waking and sleep states. Etiology, there might be a brain damage, a hemimegalencephaly or genetic mutations. It would evolve into West or Lennox-Gastaut, and the treatment is with valproate and benzodiazepine. Whereas early myoclonic encephalopathy is predominant focal seizures and fragmentary erratic myoclonias. Again, in the first 3 months, burst suppression pattern only in the sleep state. Genetic or metabolic disorders might be associated with it, but this is refractory to conventional AEDs, and hence a therapeutic trial with pyridoxine, pyridoxal phosphate and fulinic acid needs to be given. Coming to childhood, coming to infancy, when the neurodevelopment is normal, you get the seizure type. If the seizure type is myoclonic, it could be a benign myoclonic epilepsy of infancy. You see this child, this is a 6-month-old child. The child has got sudden symmetrical flexion of the tongue and the knee, and this was only during the sleep. Otherwise, the child was completely. So benign myoclonic epilepsy of infancy generally occurs in infants between 6 months and 3 years. These are brief myoclonic attacks involving arm and head, and they are just irregular and unpredictable times. They are not triggered by awakening, but they can be triggered by sudden noise or touch. They involve the axis of the body, as I showed you. EEG is interdictally normal. During myoclonus, there could be some generalized spike and polyspike wave discharges. Early treatment with valproate is indicated and prognosis is good. So when a parent complains of something happening to the child in sleep, it is very important to have a video so that you can describe the seizure. It is very important to run through an EEG so that you get the diagnosis. Now coming to 3 months to 2 years, when there is abnormal neurodevelopment. As I said, birth and development history is extremely important. When you have a normal development, the epilepsy syndromes are totally different. When you have an abnormal neurodevelopment, they are different. So look at the seizure type. When the seizure type is spasms and cluster, it is an infantile spasms or a West syndrome. When the seizure type, the history says that the onset is as prolonged febrile seizures. Later, they are generalized partial clonic, myoclonic seizures, and it could be severe myoclonic epilepsy of infancy or Dravet syndrome. And when the seizure type is myoclonic or astatic, then it could be myoclonic astatic epilepsy or Douce syndrome. Recording in progress. So this is a 4-month-old child with birth asphyxia. He comes with sudden flexion of all 4 limbs about 10 to 12 times in a cluster. You see that? There is a sudden flexion of all 4 limbs that occurs. This is a typical flexor spasm. Now, this is a 6-month-old child. Mother just came to us that the child is excessively irritable. He just keeps on crying, arching, and many doctors had just given the mother many pacifiers and many drugs, but nothing worked. When the mother was asked to take a video of the child, this is what the video showed. The child is crying and expense of father. Okay. Again, he answers and he goes. Turned out to be a West syndrome with extensor spasms. So what is infantile spasms? It is a devastating age-specific epilepsy. West syndrome consists of a triad of infantile spasms, an EEG pattern of hips arrhythmia, and developmental delay or regression. The onset is between 3 to 12 months. The peak is at 4 to 6 months. Sometimes can present without clinical spasms and with only hypsrhythmia on EEG. We already saw that it could be sudden rapid contraction of trunk of limb and musculature. It could be just before sleeping or on awakening. Flexor spasms, which you saw in the first video, are most common. 50 to 60% are flexor spasms, 20% of them are extensor spasms, and mixed are 40%. Crying or irritable behavior are often seen during or after the cluster. So the learning point is, if the child comes to in the OPD general practice or pediatric practice, and when the mother says that the child is excessively irritable, he's crying most of the times, then please do tell the mother to record a video of it. Maybe you will get a clue whether they are flexor or extensor spasms. Family history of epilepsy is there in 17%. Etiology is symptomatic in 80% of the children, cryptogenic in 20%. In symptomatic, it could be any prenatal cerebral dysgenesis, neuronal migration disorder, neurocutaneous disorders such as tuberous sclerosis, Sturge-Weber, perinatal HIE, postnatal, your PKU, MSUD, genetic. So in evaluation, a skin examination is important in all cases as tuberous sclerosis comes with infantile spasms. EEG is extremely important in early course to identify hypsarrhythmia. Neuroimaging is indicated in all cases as 80% are symptomatic. And if neuroimaging is normal, then you consider a metabolic workup, that is CSF analysis, lactate, pyruvate, and amino acids. This is a typical EEG of hypsarrhythmia, which is showing a chaotic EEG pattern. Steroids are the first drug of choice. So oral steroids 2 to 4 milligram per kg, or injection ACTH in 100 to 150 international units per meter square. Resolution of hypsarrhythmia on EEG is one of the treatment targets. Vigabatrin is the first drug of choice in tuberous sclerosis. Nitrazepam, ketogenic diet, surgery for focal cortical lesions, all these can be tried if the steroids do not work. Prognosis is overall poor. Favorable prognostic factors include if they are cryptogenic, age of onset is more than 4 months, absence of atypical spasms, absence of asymmetry on EEG. Very important is short time from onset to treatment. So I would urge that if there is a similar history, then please take the video so that the onset to treatment can be earlier, and early sustained response to treatment can give favorable prognostic factors. Last few slides, onset in early childhood. Now when the neurodevelopment, as I said, if it's normal, the seizure type is partial. If it is focal motor seizure with impaired awareness, it could be benign focal epilepsy of childhood with impaired awareness. If it is focal motor seizures with affective symptoms, it can be early onset benign childhood epilepsy. Autonomic symptoms, seizures, generally mostly in sleep, could be childhood epilepsy with occipital paroxysms or panitopolar syndrome. If the seizure type is generalized with normal birth and development, it could be absence, tonic-clonic, then it could be childhood absence epilepsy. We already saw 2 cases which you need to do an HV test. Onset in childhood, when there is abnormal development, the seizure type is mixed tonic-clonic, myoclonic, or absence or atonic, then you need to look at Lennox-Gastaut syndrome. If there is acquired aphasia, then it could be Landau-Kleffner syndrome. So Lennox-Gastaut syndrome is onset from 1 to 8 years, peaks at 3 to 5 years. They come with polymorphic seizures, could be tonic, atonic, sleep-activated tonic seizures, that is nocturnal axial tonic seizures are most common. Status epilepticus is common. 50 to 90% have non-convulsive status epilepticus, and the EEG is classical with 2 to 2.5 Hertz cycles per second. So these are very important characteristics when you want to classify as an epilepsy syndrome. Treatment, valproate, lamotrigine, and topiramate can be used. It is generally refractory. AEDs such as carbamazepine may exacerbate the generalized seizures in LGS. So why you need to know the epilepsy syndromes? Because you also need to know what you need to prevent in these children, avoid certain AEDs. Again, onset in childhood when the neurodevelopment is late childhood when the neurodevelopment is normal. The seizure type is focal motor seizures or tonic-clonic seizures, and this is the most common benign Rolandic epilepsy. If it is absence seizure in late childhood, it could be juvenile absence epilepsy. If it is simple partial or it is with awareness preserved and visual symptoms, then it is late onset childhood epilepsy with occipital paroxysms. So childhood epilepsy with centrotemporal spike is generally between 3 to 13 years. Again, these seizures are there in the night on falling asleep or before awakening. Typical focal seizures, the awareness is preserved. The child will say that there is unilateral paresthesias of the gums, lips, there is hypersalivation. There could be unilateral tonic-clonic activities. Again, this present often in clusters and they are very infrequent. Only 6% have got frequent seizures and they remit by themselves. So this is the classical EEG which shows the centrotemporal spikes. These are the spikes in the central area and in the temporal area, which are activated in sleep and they disappear in the awake state. So investigation, if the child is neurologically normal and history and EEG are suggestive of benign Rolandic epilepsy, no further investigation is needed. Achieve the remission without treatment in infrequent nocturnal focal seizures. AED needs to be started only if they are frequent or generalized seizures. Carbamazepine, valproate, and levetiracetam are the drugs of choice. So now last two slides on role of EEG and neuroimaging in epilepsy. So EEG is the most valuable, but it is the most abused investigation. It is important to use it very, very rationally. Interpretation should always be done by a person who is well versed in the subject. Routine interictal EEG will give good information in 50 to 60%. The activation procedures in an EEG are extremely important. So sleep deprivation, hyperventilation, photic stimulation, they increase the yield to around 90%. Specific indications of EEG would be to support the clinical diagnosis of epilepsy, classification of epilepsy, whether it is focal or generalized, because you would get certain focal discharges or generalized bursts as per the epilepsy, diagnosis of specific electroclinical epilepsy syndrome as we saw in West syndrome and many other syndromes. Prognostication is extremely important because if the EEG is not normalizing, there could be more recurrence risk. Ascertaining the recurrence risk before AED withdrawal. Any child with first afebrile seizure, you need to do an EEG to look if you're getting a clue. Exclusion of non-convulsive status epilepticus in cases of coma. So in the ICU, if the child is coming with coma, please do a portable EEG so that you can rule out non-convulsive status. Investigations of acute febrile encephalopathy. In any child with unexplained encephalopathy, GDD or language regression. Neuroimaging needs to be done in all children with partial seizures except Rolandic and occipital. Abnormal neurologic signs and neurocutaneous syndromes. When the EEG indicates a structural lesion. In refractory seizures, we need to do a neuroimaging. Sudden change in the seizure pattern, neurological examination or EEG. Recent worsening in epilepsy. A child with developmental delay or regression. Seizures in early infancy and when surgery is contemplated. Neuroimaging is indicated in all cases except the cases which are idiopathic, as we saw if there are certain epilepsy syndromes which you can classify on EEG and history, there is no need to do neuroimaging. Now CT and MRI totally depends on the etiology, and newer imaging such as PET, SPECT are needed prior to surgery. So the take-home message is stepwise approach will lead to early and appropriate diagnosis and hence early management. Epilepsy syndromes are extremely important not only for management but also for prognostication of the illness. Epileptic encephalopathies are devastating to the child and hence early referral for adequate management to a pediatric neurologist and to a center which has got these facilities is extremely critical. Clinical history, narration of a seizure from eyewitness and observing the video records of the seizure can help in accurate diagnosis. Thank you for your patient listening.
Thank you, ma'am. We have a couple of questions. The first question is there any specific duration for hyperventilation?
Yes, you need to do the hyperventilation at least for 3 minutes. See to it when you are doing the hyperventilation, it has to be a deep breathe in and breathe out. If the child is cooperative while doing the hyperventilation and you can tell him to count like 1, 2, that's important because you know when you are observing the child and the child loses the count, you come to know that he is going to have a seizure. So a 3-minute hyperventilation is good enough to precipitate a seizure.
Next question is, when should be EEG ordered after the first episode of seizure?
Yes, that's a very good question. So if it is a focal seizure, the EEG can be done immediately. If it is a generalized seizure, then you need to do an EEG after 72 hours, because after a generalized seizure, you can just get some non-specific slowing in the EEG. So just to avoid that, you can do it after 72 hours.
Okay. The next question is, will the aura be the same every time in epilepsy in a particular patient?
Yes, so I really appreciate, I'm glad that the audience was absolutely awake. The aura will be the same if the seizure is arising from a particular lobe. As I said, if the seizure is arising from a temporal lobe, then there would be epigastric sensations. If the seizure is arising from a parietal lobe, then there could be tingling numbness. It could be similar. Regarding visual aura, it can be a little different, and especially aura, it has localization value, but in children, as they are not able to narrate it so well. So any history which gives you that the child is feeling something funny or something happening inside, there are some, ants over, then do consider it could be a focal seizure and it could be arising from somewhere. Although it is not a hallmark, you need a correlate with an EEG and you need to work up the child further.
Right. Okay, I think those are the questions. Okay, we have one more question, ma'am. What are the indications for video EEG and continuous EEG monitoring?
Sure. So a video EEG is extremely important. First, when we are dealing with refractory seizures. So this is a workup for an epilepsy surgery. You need to have a concordance in between the EEG, the PET, the SPECT, and many things before you do an epilepsy surgery. Second, a video EEG is extremely important to differentiate whether it is an epileptic or a non-epileptic event, because even in children with chronic epilepsy, they can have non-epileptic events. Yes, video EEG again tells you a lot of information about certain epilepsy syndromes where the epileptic form abnormalities are arising from. If the child has started having clonic activities or tonic movements, then there is a focality, a point in a video EEG where the EEG changes are arising from. So it gives a lot of information when you are looking at seizures which are refractory in details and you want to differentiate in between epilepsy and non-epilepsy as well.
Okay. Thank you, ma'am. There are no more questions. Should we conclude the session, ma'am?
Yes, thank you so much.
Thank you so much, ma'am. Dear delegates, I would like to mention that the e-certificates will be issued in the name registered. So kindly requesting all of you to please rename yourselves. Moving on to the next session, we shall now proceed towards the inauguration function for the 9th DAFPAL CME 2021. So welcoming all of you again and starting with the inauguration function for 9th DAFPAL CME 2021. Our respected Dean and Patron, Dr. Mohan Joshi sir, is unable to join us today. However, we are grateful to him to send us a video message.
It gives me an immense pleasure to give this video message as a patron of this CME, which is conducted by Athavale Foundation and Pediatric Alumni of LTMGH. Dr. V.B. Athavale was an eminent pediatrician, professor of pediatrics and head of the department of pediatrics in LTMGH, and I was a student then when I learnt my pediatrics. In fact, he was one of the wonderful clinicians ever I have seen, and very kind and tender, and he had unique way of practicing the pediatrics, which was far away, more clinical and very minimal investigative or very minimal investigation oriented. He was a very kind person and he was a very good and excellent teacher of pediatrics. And it is a unique foundation which is started with his name by the alumni of pediatrics who have graduated from LTMGH. This is 9th annual CME of Athavale Foundation. The main role of Department of Pediatrics of LTMGH is that they take lead role in conducting this program, and this time the theme is Pearls of Neurology for Practicing Pediatricians. I have gone through the program, which is very unique, and I am very sure that this program and the didactic lectures which are given by the professors of pediatrics and eminent faculty members of Mumbai and Maharashtra will help. And since this being a hybrid program or this being a program which is online, will benefit large number of pediatricians in the state of Maharashtra, as well as this will benefit the people practicing pediatricians from all over the country. I am very sure that the program has got a very good menu. It has got a variety of topics which are being discussed, and there will be of great help to postgraduates of pediatrics too. Thank you so much for allowing me to give this message, and I really owe myself also to Dr. V.B. Athavale, who was one of the eminent professors of pediatrics under whom I got to learn my undergraduate pediatrics when I was a UG student in 1982. Thank you so much.
Thank you, Dean sir. Moving on to the most awaited session of the CME, the Armida Fernandez Oration. This prestigious oration is awarded to one of the senior pediatricians with a commendable body of work in their field of interest. This year, the oration is being awarded to Dr. Alka Jadhav ma'am, Professor and in charge Division of Pediatric Gastroenterology, Hepatology and Nutrition, including the Nutrition Rehabilitation Research and Training Center at LTMMC and GH. May I please invite respected Dr. Moralwar sir, President DAFPAL and Organizing Chairperson, to talk about the esteemed oration and introduce the orator. Over to you, sir.
Good morning. It's my pleasure to invite my senior teachers, members of the DAFPAL committee, and members of the Department of Pediatrics to Dr. Armida Fernandez oration. A visionary may see, but the leader must decide. It's true, and I believe a combination of the two, a visionary leader, is a rare find indeed. And we have this both qualifications in Dr. Armida Fernandez. Professor Armida Fernandez retired as a Dean of Lokmanya Tilak Municipal Medical College and was the head of the Department of Neonatology. She is the founder trustee of Sneha an NGO working on health, nutrition, and prevention of violence in Mumbai urban slums. She is also the founder of Romila Palliative Care. She started the first human milk bank in Asia and has developed many low-cost techniques for survival of neonates. An astute teacher, an excellent administrator, an empathetic philanthropist, a compassionate doctor, an inspirational role model, a generous human being. She is so much more than one can ever verbalize. The Oration Award was named after Dr. Armida Fernandez on eve of her retirement after serving as a professor and head of the neonatology and dean of the institution. Every year, the DAFPAL CME, one of the senior pediatricians, is awarded oration on her name. And this year, the award goes to Dr. Alka Jadhav. Before I call her on the screen, I would like to introduce Dr. Alka Jadhav. She is a professor of pediatrics, LTMG Hospital and LTMG Medical College, Sion. She is in charge of division of pediatric gastroenterology, hepatology, and nutrition, including the Nutrition Rehabilitation Research and Training Center. She has passed her MBBS, DCH, MD, and DNB Pediatrics from GS Medical College, Mumbai. She is a postgraduate in clinical pediatrics nutrition from Boston University. She is international board certified lactation consultant, and she has special interest in pediatric GI and liver disorders and nutritional problems, including SAM and obesity. She has held many significant positions in various organizations. She is ORSB coordinator, Mumbai zone, since last 15 years. She was on the advisory board of Regional Pediatric ART Center from 2001 to 2006. She was executive committee member, Staff Research Society, LTMGH Hospital from 2004 and 6. She is the secretary, DAFPAL Foundation from 2007 onwards. She is managing trustee and secretary, SJRF Foundation, LTMGH Hospital. She was executive committee member of pediatric gastroenterology, hepatology, and nutrition chapter of IAB from 2008 to 2010. She is advisor to Hexagon Nutrition Private Limited since 2015. She is core committee member of CMAM Association. She is life member of CMAM Association of India, and she is life member for more than 10 scientific societies. She has 33 years of undergraduate teaching experience, and she has 31 years of PG teaching experience. She has trained in various subspecialties in pediatric department. She is clinical epidemiology network through INCE from 1992. She has trained in postoperative management of liver transplant from 1994. She is endoscopy training at LNJP Hospital, New Delhi in 1994. She has trained in WHO management of acute watery diarrhea in 1994. She is PALS certified trainer from in 1996. Lactation management and BFHR training at LTMG 2000. She was trained in integrated management of neonatal and childhood illnesses. She was trained in nutrition training in infant and young children feeding practices, Delhi. She has trained in medical education training in 2004. She specialized in home-based care for HIV children in Bangkok 2005. Integrated management of children in SAM, UNICEF 210. She has clinical practice certificate in 2017. She is a postgraduate program in clinical pediatric nutrition, Boston 2015, and international breastfeeding and lactation consultant in 2018. She has many publications and orations. She has more than 25 index journals and many non-index journal publications so far. More than 40 research projects, including multiple projects with national and international collaboration. She has published multiple research papers, poster presentations at conferences, including one on an international platform. She has many awards and honors to her credit. She has established first SAM treatment unit as per WHO protocol at Sion Hospital. Established the one and the only indigenous RUTF manufacturing unit in Municipal Corporation of Greater Mumbai. She set up the first pediatric GI endoscopy unit in the public hospital. She has Vocational Excellence Award Rotary Club, Bombay Airport in 2017. She was given Lifetime Achievement Award of Rotary Club of Mumbai, Mumbai Airport 2018. May I invite Dr. Alka to proceed with the oration.
Very good morning, respected chairpersons, teachers, colleagues, and my dear friends. I would like to thank the organizing committee of 9th Annual CME of DAFPAL for offering me this prestigious Dr. Armida Fernandez oration. The topic selected is Development of Pediatric Gastroenterology, Hepatology, and Nutrition, the Journey Towards Excellence. I would like to dedicate this oration to my parents and my siblings, who have always taught me to continue working with grace despite of the situation, and to my husband, who has always supported me all throughout my endeavors in this whole journey. Pediatrics became the established broad specialty in early 80s. The need for the special care for children with acute diarrhea was felt. Dr. Athavale sir was a great visionary and encouraged the development of subspecialties in pediatrics. Dr. Meenakshi Mehta, the former HOD Pediatrics, initiated the diarrhea training and treatment unit, the first of its kind in city of Mumbai. This implemented the use of oral rehydration solution as per the WHO guidelines. I was fortunate enough to be associated with Madam and conducted many trainings for doctors and paramedic staff. These trainings were on ORS and diet in diarrhea. The department initiated ORS Day celebration in the year 2000, and I was selected as a zonal coordinator for the ORS week activity for Mumbai branch of Indian Academy of Pediatrics from the year 2002 to 2017. MBIAP received the Best Branch Award for ORS Week celebration for 5 consecutive years from 2012 to 2017. In addition to diarrhea training and treatment units, we initiated the pediatric gastroenterology, hepatology, and nutrition outdoor to cater to the children with chronic gastrointestinal, hepatic, and pancreatic problems. We also catered to the children with nutrition-related disorder. After my short tenure of working at Nair Hospital from 2006 to 2019, I returned back to my alma mater, LTMGH, that is Sion Hospital. As you all are aware, approximately 53% of all under 5 deaths are related to malnutrition. Also, the prevalence of acute malnutrition was around 10 to 12%. This was a major public health problem. So we had decided to focus more on it. The discovery of ready-to-use therapeutic food as a gold standard in the management of children with severe acute malnutrition had revolutionized the treatment of management of SAM. At the same time, destiny played its very important role. Professor Narendra Shah from Center for Technology Alternatives in Rural Area, along with Professor Shivram Murthy, Director of Toddler Food Partners and NGO from USA, approached us to set up the indigenous production unit of our ready-to-use therapeutic food and to assess its efficacy on children with severe malnutrition for an Indian context. They had 3 years experience in manufacturing RUTF at Pepsi. This motivated us and our journey began. We realized that Government of India had lot of reservations about use of RUTF in our country. Apart from its high cost, the fear was that it will replace the existing breastfeeding practices and infant young child nutrition practices. So we followed the words of Hippocrates, let food be thy medicine, and coined a new term, namely medical nutrition therapy, which we popularly called as MNT. Our production unit was established in the year 2011, and we had to import, during that time, we had to import not only the machinery, but also the micronutrients. Simultaneously, we set up the clinical monitoring unit and enrolled our first patient on 29/3/2011. We began our first clinical trial to compare the efficacy of medical nutrition therapy versus standard nutrition therapy in children with severe acute malnutrition, a hospital-based model. Preparation of medical nutrition therapy is not a rocket science. It is made from peanut butter, powdered sugar, soya oil, skim milk powder, and 22 micronutrients as per WHO specification. It is a protein-rich, energy-dense formulation giving 515 kilocalories and 14.6 grams of proteins. We procured FSSAI license in the year 2012 and kept the packaging model as a cup model since children would love to associate it with ice cream cup. SAM children reaching hospital is actually a tip of an iceberg. Hence, we decided to go into the community along with Sneha NGO and participated in their community-based management of malnutrition in urban slums of Dhara. This was the first CMAM program of our country. It is published by Sneha in the Lancet, and our contribution is acknowledged. In this CMAM program, we have had 2 models. One was a doorstep childcare model, and second was the daycare center model. In the doorstep childcare model, the Anganwadi workers would do the home visits twice a week for a period of 8 weeks. Whereas in daycare center model, it was a supervised feeding of MNT or RUTF for 6 days a week into the community feeding center established at the community level from 9 a.m. to 5 p.m. So this landmark study we have published in Indian Pediatrics. There's always a need felt for training of doctors and to have the standard training module. So we needed to train them. So we formulated and validated various training modules with the support of from UNICEF and Fight Hunger Foundation and initiated our training activity. Whenever there is a wish, there is a way. Hexagon Nutrition Private Limited took up our production unit as their CSR initiative and gave us micronutrients free of charge for first 3 years. We also collaborated with Fight Hunger Foundation for standardization and upgradation of product to an international level. We also developed association with UNICEF for the logistic support and upgradation of both production and clinical monitoring unit, both indoor as well as outdoor. We inaugurated the state-of-the-art nutrition rehabilitation research and training center in the hands of Honorable Municipal Commissioner Mr. Ajay Mehta in 2015. It's a 15-bedded inpatient treatment unit, along with a 15-bedded inpatient treatment unit along with Uma Kendra. Uma depicts Upchar, Mamata and Ahar, and she is the goddess Parvati, which is Ganesha's mother. Since the year 2017, we received a strong support from Tata Motors as their CSR initiative. And from year 2018, our work was recognized by municipal corporations to a great extent, and we got a complete logistic support for our NRRTC with the annual grant of rupees 50 lakhs. In the year 2021, our NRRTC was approved as MCGM's nodal center. It was a feather in the department's cap. We have also received the additional support from Urban Health Mission. At LTMGH, we take care of children of all spectrums of malnutrition, ranging from SAM, failure to thrive, till overweight and obese patients. We also have preventive nutrition activities like infant and young child nutrition outdoor that takes care of children at risk, also supports breastfeeding practices and prevents them from developing a nutritional deterioration. Visit to NRRTC is included in our undergraduate curriculum. As a nodal center, we have been associated with various hospitals, to name Dr. R.N. Cooper Hospital and Govandi Shatabdi Hospital, where we have assisted them in setting up of NRC. We do give them medical nutrition therapy or RUTF. We do the data monitoring and handholding. At Tata Memorial Hospital and Comprehensive Thalassemia Center, Borivali, we issue them low folate medical nutrition therapy to cater with oncology related malnutrition. We conduct the training sessions for medical officers, the resident doctors on SAM diagnosis, red flag signs, and infant and young child nutrition practices. We are implementing the community-based management with the help of various NGOs and ICDS in Dharavi and Govandi. To name a few, Sneha, a Foundation for Mother and Child, Action Against Hunger, Save the Children, Apnalaya, etc. We support them for confirmation of diagnosis, treatment support by providing them with RUTF or MNT and monitoring, imparting the training to their staffs, doing the telecounseling and telemedicine, and ensuring the follow-up and monitoring. This telecounseling and telemedicine we have developed as a COVID appropriate behavior. Our work did not stop. Till date, we have managed around 3,000 children with severe acute malnutrition and 3,000 with moderate acute malnutrition. With telemedicine services, 27 children have been managed, 1,000 severe thin and thin respectively, 600 children with failure to thrive, around 200 children with high risk which are counseled, and 53 overweight obese children. We have conducted many clinical trials about use of MNT in various conditions and in various settings like oncology, other organic conditions. We conducted the first state level SAM training workshop for the medical officer, and till date we have conducted 48 workshops for various healthcare professionals across the state of Maharashtra. We already had a GI, gastrointestinal and hepatology specialty outdoors since 2002. There was a pressing need to strengthen them by establishing the luminal gastroenterology services. So we started our first pediatric endoscopy unit with the support from our adult gastroenterology unit and pediatric anesthesia unit. It was the first of its kind in MCGM hospital. Along with interventional radiology, we also started doing the vascular procedures. My colleague, Dr. Prachi Karni, who has contributed significantly towards the development and upgradation of this scopy unit. We have collaborated with international radiologists for vascular procedures and also intensified our therapeutic endoscopy procedures. Next. We are identified as a training center for National Fellowship Training Program conducted by ISPAGA. we get referrals from various hospitals. So apart from hepatic venoplasty and stenting, we do various therapeutic procedures like esophageal dilatation, foreign body removals, polypectomy, feeding gastrostomies, and many more. Next. So we conducted the first endoscopy training workshop at national level in Pedicon 2018, the first of its kind in the state of Maharashtra. Children with chronic liver disease and acute fulminant failure need the care with an expertise. Also, jaundice in early infancy is a special chapter by itself. If ignored and neglected, they land up with the need for a liver transplant. In our pediatric hepatology OPD, we take care of such children with regular monitoring, timely intervention. Pediatric liver transplant services are not still available in NCGH. So we developed a public-private partnership model, and since last 3 years, 4 of our patients have undergone the liver transplant. Our annual scopy workload is around 300 to 350 children who have developed the scopies, and around 600 to 700 children they under new cases which are referred to us. Okay. ज्ञानातील एक गुंतवणूक सर्वोत्तम व्याज देते. So investment in knowledge is the best investment one can ever have. So our center is approved by Maharashtra University of Health Sciences and as well as Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition as one of the training centers for the fellowship program in gastroenterology, hepatology and nutrition. We are also affiliated to SVT College of Home Sciences, Zuhu, an autonomous institute as a training center for postgraduate program in pediatric clinical nutrition. I was invited as a key speaker for various international platforms to name in 11th SEA Regional Scientific Meet at Nepal, 31st Network Conference of TUFH at Brazil, and SIOP Asia Conference in 2017 and 19 to deal with our oncology related malnutrition. Here are few glimpses of our research publication. In year 2015-16, we published our first technical paper on indigenous production of ready-to-use therapeutic food. We also published our first randomized trial on control trial on use of medical nutrition therapy indigenously prepared on children with severe acute malnutrition, a facility-based study. It showed a good recovery with a rate of weight gain of 7 grams per kg per day. So we dropped the standard nutrition therapy limb and we continued with only MNT limb with ethics permission. Then comes our landmark study on stating the use of medical nutrition therapy in hospital-based model as well as in community-based model, published in Indian Pediatrics. Here we have found that in a RUTF-based model, we are seeing around 40.7% recovery rate versus in standard nutrition therapy, the recovery rate was 19.3%. And amongst the two community-based model, the DCC model or the daycare center model revealed the best result with the weight gain of 11.2 grams per kg per day. So we focused on use of, definitely the need was different. Oncology related malnutrition was a significant problem. So in collaboration with Tata Memorial Hospital, we performed a study where we used low folate medical nutrition therapy in oncology related malnutrition. It's actually a new strategy and never used before anywhere in the world. It revealed a good outcome and a tolerance. And the tolerance to chemotherapy was much better with less disruption during treatment. This study is published in Pediatric Blood and Cancer. We also used a medical MNT in HIV related malnutrition, which was also of great help. The cost of the treatment with conventional ready-to-use therapeutic food is around 4,000 rupees per child for a duration of 8 weeks. It's very expensive, and that's why we felt there's a need to develop a low-cost MNT. Here we modified the composition and we used processed soya flour and prepared a soya-based MNT that could reduce the cost per day almost by 2/3. So here we used it for our SAM children as well as young children with failure to thrive, and the results were comparable with conventional medical nutrition therapy. We did not stop only at SAM. We expanded our wings and used this MNT for severe teen children, that is children above 5 years of age. We studied the weight gain and rate of weight gain, which was definitely significant, and it was very effective. We also studied antioxidant levels and change in the lipid profile. There was a significant improvement in the antioxidant levels, and there was no significant dyslipidemia observed in the population we studied. Because MNT is a protein and lipid-rich formulation, we also studied the impact of MNT on body composition analysis. And contrary to our expectation, there was a relatively more gain in the muscle mass as well as fat-free mass. So we analyzed, so this was very important observation to be noted. We also analyzed the effect of SAM on quality of life and also studied the infant and young child practices which gave birth to the SAM. So for children with moderate acute malnutrition, we did a community-based study. We studied the efficacy of formulated ready-to-cook and ready-to-eat food with government take-home ration in the community-based approach. The results were very encouraging. We have participated in ICMR rotavirus surveillance network first and second. The third one, surveillance is ongoing. Other completed international clinical trials are Pediatric International Intensive Care Survey, utility of digital stethoscope, and micronutrient assessment in unaided children, children from unaided school. Our team received many awards at the national and state level conferences. Our student, Dr. Prachi Karnik, stood first in the merit at Ispagan exit exam. I was awarded the Lifetime Achievement Award in 2018 by Rotary Club of Mumbai Airport. Many things we could do. Many things have yet to be done. We need to focus more on Kuposhan Mukt Mumbai by 2025. I believe every medical college and hospital must have NRC with the referral facility available. We must also develop medical nutrition therapy for wasted pregnant mothers to prevent the malnutrition in utero. We should promote the breastfeeding and infant and young child nutrition practices rigorously, and every pediatric department must have a pediatric nutrition unit catering to a various subspecialties ranging from intensive care to the sports nutrition. We should be equipped to deal with double burden of malnutrition, that is overweight and obesity. We need to have a registry set up for common GI disorders along with the genetic workup. The drugs for chronic illnesses must be available free of cost across the board. We need to set up the green corridor for emergency referrals for children with acute GI bleed, hepatic encephalopathy, and also need to intensify yellow alert movement by popularizing stool chart. We should facilitate early referrals of infants, and there is a need for a strong public-private partnership model to prevent the delays. We have been appreciated widely and covered by the media. Many people have come and visited our book to name the few. We have Vandana Krishna Madam from Jizau Mission, a team from Bhopal, the team from Rajasthan, and the ICDS Commissioner visiting. Next. We have international visitors from US Consulate, other team members from UNICEF Delhi and government official Afghanistan. So these are few of our glimpses of our activities like cooking demonstration. Then we have we celebrated our first birthday of our NRRTC. So that first birthday celebration, we have Christmas parties, we have Children Day celebration, and during COVID, we still celebrated mask distribution with the help of hexagon farm. We continued our activities during COVID by having online lectures and online trainings. Also the online services with the help of telemedicine and telecounseling. We continued holding meetings with stakeholders and NGOs. I believe a strong desire, we can dream big. Destiny will play its role. A good decision making and determination, along with a positive action in a positive direction, with guidance and supervision from seniors is required. A dedicated team, dependable colleagues with a good driving force makes deliverance possible. How can I forget my 11th D, that is generous donors, all throughout my journey? Apart from MCGM, we have been supported various donors at the from various times. To name few, we have Toddler Food Partners, UNICEF, Hexagon Nutrition Private Limited, Tata Motors, and for Skokie unit, we have UNICEF, Shraddha Charitable Foundation, and Tata AIG. I owe a lot to my cute little patients. They taught me a lot. In this journey of 32 years, many friends, well-wishers, colleagues, and seniors all have encouraged and assisted in making my dream come true. Dr. Meenakshi Mehta, who inspired me, Dr. Mamta Manglani Madam, who was instrumental in mentoring my nutrition project, Dr. Radha Gildiar Madam, who was a motivating force for documentation and getting our center recognized as MCGM's nodal center, Dr. Vishnu Biradar and Dr. Prabha Sawan Madam for assisting in initiation of Skokie services. Dr. Vibhor Borkar has continued support and valuable inputs. Dr. Prachi Karni, my right hand, for all her endless efforts, dedication, devotion, and walking all along with me since last 7 years. And Dr. Aditi Kolte, a brilliant girl with an added support to our team. For my nutrition team, I owe a lot to Dr. Professor Narendra Shah and Shivram Murthy for sowing the seeds of nutrition center. My nutrition team, Dr. Lavina Fernandez, to take up the responsibility of production unit. Blossom Rodriguez and Divya Ananda Subramaniam for shouldering and clinical monitoring unit as well as academic collaborations. Dr. Annapurna Kohli for her clinical inputs. Dr. Yashwant Gabale for taking care of my telemedicine limbs and services. Deepali Salvi for accurate and meticulous accounts from time to time. I'm also thankful to Dr. Mona Gadre for her valuable inputs. And I also express my gratitude to all my colleagues and support staff in our department. It is difficult to list all who have supported. I owe them a lot. If I have inadvertently, I might have forgotten somebody, so please excuse me for that. I would like to acknowledge the strong administrative support from my dean and all our deans and directors. I believe the best is yet to come, but you must put in very best. In last 32 years, to the best of my knowledge, I have tried to put in my best. I hope the best will definitely come. Thank you.
Thank you so much, ma'am. You are an inspiration to many, many young doctors, including myself, and I feel blessed to be learning pediatric gastroenterology under your guidance. I would like to mention that this session is supported by Hexagon Nutrition, who have been generously donating and supporting our NRRTC. May I please invite Dr. Radha Gildial Madam, Organizing Chairperson, to read out the citation for Dr. Alka Ma'am. This citation has been beautifully penned by Dr. Prachi Karnik, who has worked in close association with Alka Ma'am for the last 9 years. Over to you, ma'am.
Thank you, Aditi. To achieve more, one has to risk more and dream more. Risk more than what others think is safe. Dream more than what others think is practical. The Dr. Armida Fernandez Oration 2021 awarded to Dr. Alka Jadhav. Through this oration, may people know you more than they actually do. You do more than diagnosing diseases. You understand the untold story and channelize the story gone awry. You have an eye for the invisible sign, for the faintest sounds, a ear so fine. You do more than just treating children. You heal the body, the mind, the soul of the patient, parent, and the family as a whole. You reassure and comfort. If need be, you scold. The best for each child, the motto you firmly hold. You are more than a teacher. You are a counselor to a problem-filled student, an advisor to one who seems imprudent, a confidant giving a tolerant listening ear, a mother lovingly wiping the homesick tear. You go beyond the mundane, upgrading pediatric gastrohepato services, your dream, your biggest ambition. Nutrition Rehabilitation Research Training Center, your baby, your deepest passion. Among these sister quarters, a beautiful balance you strike. That's been your secret mantra to achieve so many firsts of its like. The first NRRTC in the state, the first to produce RUTF indigenously, the first and only MCGM setup doing pediatric GI scopies exclusively. You have been more than a boss. You are a mentor to many a student, staff, subordinate. To go beyond your duty, not even for a moment you hesitate. A philanthropist, you do whatever it takes to uplift even the lowest in the rung. At times, even shelling out of your own pocket, you leave no stone unturned. You live beyond the present. You are a visionary, an out-of-the-box thinker, open to progressive changes. Sion, your karma bhumi, wouldn't find another like you for many, many more ages. Thank you so much.
May I now please request Organizing Chairpersons Dr. Moralwar Sir and Dr. Radha Gildial Ma'am, Organizing Secretary Dr. Mona Gazre Ma'am, and Treasurer Dr. Yashwant Gabhale Sir to honor and felicitate Dr. Alka Jadhav Ma'am with Shreefar, shawl, the oration plaque and citation. We would have loved to have Dr. Armida Fernandez Ma'am in person for the felicitation, but we are glad that she is joining us live on the online platform.
I'm really overwhelmed by the. Thank you so much for all love and the blessings. I think I need all your blessings for the same, for continuing working with the same figure. Thank you.
Thank you so much, ma'am. After that wonderful oration, moving ahead with the CME, as is the tradition of the foundation to felicitate the meritorious MD and DCET students every year. This year, we will be felicitating meritorious students of the last 2 years since we were unable to conduct a CME last year. For the year 2021, we have Dr. Shreyasi Biswas standing first amongst MD students and Dr. Shrikant standing first amongst DCET students. For the year 2020, we have Dr. Swathi Krishna standing first among the MD students and Dr. Sheikh Irfan Sheikh Manan standing first amongst DCET students. On behalf of Department of Pediatrics and DAFPAL, many congratulations to all of you. Moving ahead with the academic session. Our next speaker is Dr. Anaita Hegde ma'am, President of Association of Child Neurology India. She is affiliated to SRCC Children's Hospital, Jaslok Hospital and Bhai Wadia Hospital. Her special interests are epilepsy, disability and movement disorders. Ma'am will be talking about genetics in neurology. Over to you, ma'am.
Good morning. Thank you. That was very touching. That entire session before that, to follow that is going to be difficult. Congratulations, Dr. Alka and the entire team for everything you do. My topic for today is genetics in pediatric neurology, a case-based approach. And what I'm going to cover today is the role of genetics in clinical practice. The advent of genetics has changed the way we practice child neurology. It's a huge leap in the last decade, more than we've ever had in the entire last century. Diagnostics, not only does it help in diagnosis, but also understanding of the phenotype-genotype correlation, the pathophysiology, and thereby now we are getting treatment options which we could have never dreamt of before. And all this has been happening at breakneck speed. So just to give you a little history as to the timeline, what started in 1869 with the discovery of the DNA, and then we all know about the double helix that came in, then the first PCR which came in. The main chunk or the main development in genetics happened between 1990 to 2002, where the whole genome program was created. The United States and Europe invested large amounts of money into the creation of the whole genome, and we'll go into that a little bit. But here you can see the number of publications with regards to genetics and the number of studies which are coming out with genetics over the last few years only, which has been there. Sorry. As you can see, this is the advent of the genetic thing which has started over here, and it was in 1990 that the whole human genome project happened. And this is all that has happened in just a span of 10 to 12 years of dedicated work into research. We started with everything came out over here. The CRISPR was discovered, splicing came out, newer modalities, oligonucleotides came out, and a whole spectrum of treatment options as well for genetics. Sorry. So here you can see again the discovery, but these are the tests that are available. And if you look at the Sanger sequencing, the ease of analysis is maximum over here in the Sanger sequencing and least when you come to the whole genome. And that's the amount of genetic material. So the ones which are easier to do give you less genetic material or less genetic data. The ones which are more difficult to do, and obviously cost comes into the issue out here, you get far more genetic data. But it's interesting to know that cost is also something which is now on our side. And I would like to let you know that what we get in India is maybe the cheapest in the entire world at the moment for genetic testing. So this is what it was when it started in 2000, and we're all aware that we used to pay so much more at that time. And this is what it is today in 2020, and hopefully it will go down even further. So here we have the genetic testing grows in popularity, as you can see over the years. And this is the amount that is expected to be the money spinner that genetics is going to make. And here we have an understanding that while nutrigenomics testing, okay, so we are all aware of the gut genetic testing that happens. And then targeted analysis is where we are. And hopefully, or they are presuming that it will go into over-the-counter very soon and online platforms very soon. So not only is it something which is helping us as clinicians, it is soon going to be something that the lay person can access routinely to find out about himself or his future. So what are we going to cover today? Now that I've covered the impact of genetics today and tomorrow and in how it's going to affect our practice, for whom would you consider genetic testing? What genetic test would you like to choose? How would you interpret the results of the genetic test? And how do you use these results to guide treatment strategies, what you call precision medicine? So for whom would you consider these testing? This is a young 28-day-old male child who came to us. Multiple episodes of paroxysmal movements, staring, clonic jerks on one side, both sides, upper limbs, up-rolling, fluttering, subside within a minute or so on their own. And on examination, we have a decent head circumference, but marked hypertonia, scissoring, fisting, incomplete morose, and poor activity, virtually no development since the onset of the seizures. He was treated with levetiracetam, phenobarbital, with no improvement at all. And when he came in, this was his EEG with almost like a migrating epilepsy to some sorts, keeping in mind that that is what we might have had. So we had acute onset refractory seizures in the first month of life, multiple seizure semiology, did not respond, and no milestones attained. At this time, would you send genetics? Most definitely, yes. And if so, what would you do? Yes, if at one time we had epilepsy panels, today we have the clinical exome or the whole exome, and I strongly recommend to go for the whole exome. It saves you having to repeat a second test after a few months. So keep that in mind. That one was an intractable, aggressive epilepsy, not responding to any medication. We sent off the genetics, but yes, in that sort of situation, you can't wait for the genetic result to come in. We tried something which we'll come to as we go into precision phase. The second one was a 6-month-old boy, first issue of a 3rd-degree consanguineous marriage, normal birth, antenatally hypothyroidism, preterm child, high-grade fever at 1.5 months of admission of age, admitted for 3 days. Development is absolutely age appropriate. At 5.5 months, he had his first event and subsequently had multiple seizures per day for a few days. He required ICU admission. He was treated with multiple AEDs, and eventually the seizures came under control with 5 or 6 drugs. Metabolic screen was done, MRI was done, and it was at this time when we were reviewing that the grandmom came in for the history, and she gave us this entire history of so many family members, but she also told me, we're not so worried because this one is a lawyer, and this one is a school principal, and this one is a judge somewhere else. So we realized immediately that whatever we were looking at didn't have such a malignant outcome at the end of the day. The next one we are going to discuss is a 3-year-old boy, a child of a 3rd-degree consanguineous marriage, loss of appetite, abdominal pain for a week, vomiting for 2 days, icteric and irritable, encephalopathic, OTPT were massively elevated, went into liver failure. Cause of it was sought, and everything from infection, inflammation, autoimmune, everything came negative. They actually contemplated liver transplant for acute liver failure. However, the child gradually improved on his own, not responding to commands. When a reference was made, once the child came back into the ward, and we found that we had significant delayed development with regression of milestones after this episode. And we had this host of involuntary movements with dystonia, dyskinesia, and all we could do was treat symptomatically because of the movement disorder. Given this underlying picture, we did put symptomatic. We also put him on the mitochondrial cocktail, and we sent off his genetics, and we would await that. The next case we're going to go through is a second child of 4th degree consanguineous marriage, cried soon after birth, development delay, severe hypotonia since birth. Since 6 months, had continuous episodes of uprolling of eyeballs, continuous severe dyskinetic movements, and continuous movement, a host of movement disorder, and just everything from hypotonia, dyskinesia, dystonia, oculogyric phenomena, sweating, loose stools, excessive autonomic involvement. So we thought we were looking at a neurotransmitter disorder. I tried to put him on Syndopa. It didn't make any difference. Then we sent off the CSF for off to Barcelona at that time. This is 10 years ago plus. It came back neurotransmitter positive for AADC. And the child has been with me for 10 years, but it's been a lovely journey from struggling to get his diagnosis. The advent of genetics came, the gene was picked up immediately, and literally within the 10 years of his lifespan, not only did they identify the gene, they've done research in gene therapy is out on this child. So we'll come to this a little later. Case 5, he's a 7-year-old boy of fraternal twins, difficulty in getting up from sitting position, toe walking since 6 months. You've got the picture directly, Gowers positive, calf hypertrophy. What test would you have done at this stage? You don't need to do a whole exome here because you know you're looking at just a DMD most likely. So you can do the DMD gene, and if it's negative, you could go in for the whole exome. Came positive. So you might wonder, why would I put this in today? But we'll come to that down the line. And the last case is a 9-month-old child, again with intractable seizures. EEG showed burst suppression pattern, started with infantile spasms, modified hips arrhythmia, treated with numerous AEDs over the time, and then eventually vigabatrin, no features of tuberous sclerosis at all, but vigabatrin did the trick totally. So what are the risk factors that you're looking at when you're looking at genetics, when to send the genetics? If you have acute onset, aggressive regression or epilepsy of any form, if you have a family history of consanguinity, either immediate or distant, if you're looking at a child and you can't find the etiology, there's a normal MRI, metabolic screen normal, EEG is looking relatively either good or is not giving you a diagnosis, if you have developmental delay or regression, or if he has syndromic features. Okay, we send off the genetics. So which genetic tests would you choose in all these circumstances? So what started off with only karyotype when I was a student, today you have this host of, or this basket of gene testings which are available from the MLPA, the CGH, the mitochondrial, the NGS, the trinucleotide repeats. So you must know what you're suspecting because you need to know how to ask for the testing because each of them costs. So if your patient looks dysmorphic, a microarray would be the most likely one, but trust me, sometimes the yield of a microarray is only 20% or so. So very often an NGS also will pick up, next generation sequencing will also pick up dysmorphic features. If you're strongly suspecting either epilepsy, metabolic, neurogenetic, neuromuscular, any of the entities I've said, you could have sent a gene panel for them. If you're not sure, or if he has symptoms of multiple panels put together, so he's got this movement disorder and epilepsy, you don't know which panel to choose, then you're safest with a whole exome sequencing. And you could do a microarray if you have any other features of delayed development prior to the onset, etc. If the microarray is negative, you then go for the whole exome sequencing. And if you have multiple features of it, you've got a syndromic child and you've got movement disorder and you've got epilepsy and he's hypotonic, then you're safer off with exome sequencing with microarray. So this was a young child who had delayed development, seizures, multiple AEDs. He was ataxic. He had a very happy demeanor, microcephaly, no speech, autistic features, loud mouth, unexplained laughter. So putting it like this, the diagnosis almost give away, but he went through all the tests positive from NGS to CNVs. Everything was done on him. Sorry, negative. And he had, these were his salient features. So what tests would you do? His NGS was negative, his CNVs, his microarray came negative. Would you have done a whole genome after this? Would you have done repeat NGS with CGA, Fragile X, karyotype, or MLP? And we did MLP and it came out positive for Angelman's. So basically, you must have some clinical idea as to what you're looking at so that you learn to choose your test. For Angelman's, MLPA would be your investigation of choice. And if you fall negative of those, you will go down the sequencing of other variants which are possible. This was a 1 year, 3-month-old child with seizures, normal delayed seizures at 3 months, started on AEDs with no response. And we have tonic seizures. This was the tonic seizure that you have in this young child at 8 months of age. We have hypotonia, subtle dysmorphisms, fair child, normal ophthal. She had been this, and our genetic report, these were her features. Our genetic report stumped us. We had 2 things which came pathogenic. One was CDKL5, which fit the picture because she looked like an epileptic encephalopathy. And the other one is IRF2BL, which is for development delay, regression, abnormal movements, loss of speech, and seizures. So how do we interpret? Now you've got 2 genes, which not possible to have 2. How do you interpret these? So when you're interpreting the report, we have a spectrum of genetic reports which come to us from benign, likely benign, VUS, or variable of unknown significance, likely pathogenic, and pathogenic. When it's pathogenic, your answer is usually straightforward. Okay, so the 100% confidence variance that it's there. Likely pathogenic is roughly 90 to 100%, so it's almost clubbed in the same category. A VUS has a 50-50 chance or a little more chance that it's negative than it may be positive, and these 2 are on the benign spectrum. So when you have your reports, 2 things come. One is your primary finding, and your primary finding is usually what you are looking for. And very often, so I have written there intractable epilepsy, normal facies or dysmorphic facies, whatever, they'll give me a report which will be my primary finding. My secondary finding is an incidental finding, which given the data that I have given to them, you might actually pick up another gene or something which is not what the doctor was looking for, but may contribute to some extent into the report. So when you're looking at pathogenic or likely pathogenic, it's usually the cause of the patient's symptoms. Usually the cause, as you can see, the one we are discussing had 2 pathogenic genes, which is not possible. And a likely pathogenic or pathogenic means it's most likely has a harmful effect on the patient. Uncertain significance of VUS is the most difficult one for us to interpret down the line. So what you need to do over here is you need to take parental segregation and you need to send parental sampling as well. And you will reclassify. So if the child clinically fits and both the parents are negative for it in a heterozygous deletion, then you could say that this is a de novo mutation and we'll go to that. And you could say, you could then reclassify that gene as significant. So let's take this. The child is CTTA and both the parents are CGTA, both equal. So obviously this gene, so when I send this segregation and I saw parents are both normal, only the child has CTTA in him. That means this is a de novo mutation and it is not inherited. This has multiple importance. One, you could specify it and say that this gene is significant and it will go into literature and tomorrow it will be recognized. After many more like this, it will be recognized as a significant gene and it will move from VUS category to likely pathogenic category. And the second thing is you can counsel the family that this is not inherited. One, it allays their anxiety because from which side has this gene come or who has given this gene to that child. And second is for the next pregnancy, the child, they don't have to worry. They can go ahead with the normal incidence of genetic malformation. So when we saw this gene, what we did is with the parents, What we have is out here for both the genes. The father came positive for the IRLF gene. So its father is totally asymptomatic. So this variant became invalid. Whereas both the parents came negative for the CDKL5 gene, the child has totally pathogenic and fit the picture clinically. So this became a de novo mutation. Ideally, you should go back to the genetic company, inform them so that they can upgrade this gene from de novo into significant. So now you come to using these genes and how do we use them to treat these patients. You remember the first child, we go through each of our cases. We had an epileptic encephalopathy starting within the first few days of life, not responding to any treatment. So what we did is, suspecting that we were looking at partially migrating epilepsy, we put the child on phenytoin, which is really not the drug we use in the newborn period now. So I could have used phenytoin or carbamazepine, and literally the seizures resolved within a few days. So the studies came SCN2A, which is known to respond, and we'll come to that. And it's very interesting to note that in SCN2A, or these rare genes, if you actually treat the child within 7 days of the onset of the seizures, they can come out with normal development. If, however, we miss that window period, the outcomes can be very poor in spite of controlling the seizures totally. So at 6 months follow-up, he has no seizures, but he has severe global developmental delay despite the aggressive rehab. So we gave him the right drug, anticipating the gene, but we had missed that window period where we could have treated him. But down the line, once we are more aware of the genetics and we started on day 1, we might be able to change the picture. So this is an important table to understand. So if you have an SCN1, if you have febrile seizures after 3 months of age, it's usually a loss of function. They respond very poorly to sodium channels. So when you say all the SCNs are sodium channel genes, if you have SCN2 and you start before 3 months, it's usually a gain of function. They respond well to sodium channels. After 3 months, it's a loss of function, they're resistant. And thereby SCN3 and SCN8A, the similar thing. So if you have seizures, intractable seizures, less than 3 months of age, you are usually a gain of function and you will respond well to sodium channel drugs. If they present after 3 months of age, you are usually a loss of function and they will be resistant. They actually will get worse with sodium channel drugs. So it's very important that we know what age of onset these seizures were, and then a better understanding has evolved. And this has largely been literally in the last 2 to 3 years, once the sodium channels have been out and we have understood. So you can see here later onset seizures, more than 3 months, loss, poor response, earlier than 3 months, gain of function, good response. So the next one that we come down to was the little child who was absolute normal development. And the grandmother told me, don't you worry, everyone in our family has had it and everyone has become really good. So that gave me a sort of a comforting feeling. So it looks like we're looking at a self-limiting epilepsy. Cognition seems intact. So would you still send genetics in this case, or would you just say, you know, let's keep trying different drugs and hopefully it'll all get better down the line? So what does the genetics do? It identified the drug or the treatment that this child will respond to best, and the long-term picture. So what we got was a PRRT2 gene, which has neurological features as well as movement disorder. But the movement disorder comes in the 2nd decade usually. So the neurological features will tell you that they respond very well to carbamazepine, oxcarbazepine, other drugs like that. The seizures may be of different variants. They have normal psychomotor regression. They might have migraine. They might get movement disorder in the 2nd decade. So one is you can change your drug. Second is you can counsel them accordingly that, listen, this is nothing to worry, but do be prepared that in the 2nd or the 3rd decade of life, you might end up with a spectrum of movement disorder, which is also relatively benign. So the 3rd case we had was the child who came with acute liver failure, and the whole treatment was on the liver failure and the neural regression which happened afterwards, as well as the movement disorder. And taking detailed history, noted that the child was delayed right from the start with sensory issues. As per the mother, his understanding was not at par with other children his age, and he had episodes of regression in the past following infections, but would recover after that. So here we have consanguinity, history of regression, no other cause for acute liver failure, MRI picture with basal ganglia involvement, and what genetics would you have sent at this stage? And if yes, what will you send? So given this history, that the child was delayed to start with, slightly delayed, and would regress with every infection, even in the past, mitochondrial rung a bell with us. We sent off the whole exome as well as mitochondrial, and we found a gene which was a homozygous variant, pathogenic variant. And the important thing was, yes, they have 3 variants to this gene, 3 phenotypes. A neurological one where liver transplant is an option, a hepatic one where they say liver transplant has not worked in the past, and a myopathic one, which our child did not have any features. So at this given moment, not only did we get the diagnosis, we also knew how to process him, whether we should push for the liver transplant, or we reviewed the literature and realized whether it's not going to benefit him or not. The 4th case was a second child of a 4th degree consanguineous developmental delay with continuous watering of his eyes, frequent episodes. We had picked up that he was AADC on neurotransmitter disorder. We then sent off his genetics, which confirmed his neurotransmitter disorder. And this has been an amazing family, very simple, but they have done everything possible for their child. They've contacted all the centers that are doing gene therapy. At the moment, they are in the process of applying. They're applied for gene therapy. They are fundraising, and hopefully their son will be going for gene therapy. But Veer at this given moment is maybe the oldest living AADC in the world. He's almost 12 years old now. And it's been an amazing journey from when I started not having any genetics in hand to getting the genetics, and now being able to see that, help the child, forward him to someone who's doing gene therapy. In 10 years, 1 decade, we have seen this entire change. Case 5 was the typical DMD child. We did the DMD, we picked up the exon, but as you are aware today, DMD is not just DMD. We have lots of exon skipping available. We've got gene therapy, which is in the pipeline as well, not just abroad, but even in our own country. We have teams which are working on gene therapy out from our own country, so we should hopefully have something. But you understand, knowing which exon is very important, because exon skipping is not available for all DMDs. It depends on which exon you are, and then they can consider the exon skipping for them. And the last child, again, we thought was an epileptic encephalopathy, infantile spasms, burst suppression, or hypsarrhythmia. Did not respond to everything, but responded to vigabatrin after a few months. And what did we got? We got a DAPDC5. Now, what does this infer? So you sit down and you read when you get a gene which comes like this. And DAPDC5 works on the mTOR pathway just like tuberous sclerosis does. So once you understand, or you get a gene diagnosis, you can understand how it works, and then you can take a drug from another category and put it into this category. This is called repurposing of drugs, where you use a drug which works somewhere else, and then you put it in for another gene because it works on the same mechanism that is there. And I think ever since this has happened, we have moved so much in tuberous sclerosis. This is the first entity that we can now treat children before they get their seizure, so that we can change their life and their outcomes. If you wait for the seizures and treat them, their outcomes are limited. But if you can treat them before the seizures come by monitoring the EEG, and now there are ways, there are systems, and there are epi-stop studies, etc., to show you, you can actually, it is life-changing for this child. So if you see, case 1 was refractory infantile epilepsy. We understood the ion channels. We tailored the treatment. We started the CBZ, the phenytoin, and less than 3-month onset, and we got very good outcomes. The second was a benign epilepsy, which came with an aggressive acute. In real time, it came very aggressively, but actually turned out to be benign in the long run. But a strong family history, the treatment and counseling made a difference. Movement disorder with acute liver failure, early diagnosis could be life-changing, saving and changing, life-changing as well. The next was a neurotransmitter, which was a movement disorder, followed up for 10 years. And we've seen the struggle from how to just to get that CSF across to Barcelona, minus 70 degrees, it had to reach within 48 hours of you collecting the sample, to now giving that child gene therapy after the genetic report. Neuromuscular simple DMD, where the population is huge of these conditions, if we can get oligonucleotide or gene therapy coming in soon, it will be life-changing for a huge population of children with disorders. And again, intractable epilepsy. Here we repurposed a drug from one indication to another indication because we understood the pathophysiology of the gene and we could learn how to adjust our drugs. So in conclusion, genetic testing has changed the way we practice child neurology. Truly, from what it was as my resident days to now, it's just unbelievable what we can offer our patients today. The red flags for whom to test, we must keep that in mind and put our antennae up. There are numerous benefits of early testing. I do believe that clinical judgment can never be circumvented, and you have to do the entire clinical profile and work up your patient. But an early diagnosis can also give you a lot of benefits, as I've highlighted to you, that if we can treat early, we can change the life in many of these children. So choosing the right test so as to increase the positive yield, help in prognostication, and it closes the circle for the parents, helps with antenatal counseling and future pregnancies, and most important, treatment options, conventional, gene-specific, tailor-made, and it also is ongoing research, repurposing drugs, novel genes, and gene therapy. With that, I'd like to thank you and invite all of you to our next Child Neurocon, which is in Ahmedabad in the last weekend of February. We would love to have all of you over there to learn more on what's latest in child neurology. Thank you.
Thank you, ma'am. Wonderful session. We have a question from one of the delegates. The question is, if on whole exome sequencing, the child is found with heterozygous mutation, which is also found in one of the asymptomatic parents' heterozygous state, how will we interpret it?
So that's what we put down in interpretation. So if the parent is carrying the same thing and the child is carrying the same thing, child is symptomatic and parent is not, that gene is not the responsive gene. That gene is not actually causing your problems. You would have to ignore that gene and keep working in other ways.
Thank you, ma'am. I think there are no more questions in the chat box. Can we conclude the session, ma'am?
Thank you.
Thank you, ma'am. Thank you so much. Moving on to our next speaker, Dr. Shekhar Patil, sir, consultant pediatric neurology and epilepsy at Apollo Hospital and Neuroclinic Chembur. His areas of expertise are complex pediatric epilepsy, epilepsy surgery, pediatric neurometabolic diseases, neuromuscular diseases, and adult neurology. Sir will be talking about pediatric stroke and its management. Over to you, sir.
Thank you. So I thank the organizers for the conference to give me this opportunity. And today I'll be talking on the management of childhood stroke or pediatric stroke. So what we're going to really look at is the epidemiology of stroke, types of stroke, what sort of imaging we really ask for, discuss a few cases and management as we move along. So why do we actually need to know about stroke? So even though we are looking at a lot of strokes in the adult world, we also need to understand that, yes, even in a child, we can encounter a situation where we're looking at a stroke. It could be an ischemic stroke, it could be a hemorrhagic stroke, or it could be a stroke after a venous sinus thrombosis. So multiple studies have looked at the incidence rate, and we have incidence rates varying from 1.
Excuse me, sir. Sorry to interrupt you. Could you please start your slideshow on? Yeah. Thank you, sir.
So just going back, so we need to know about strokes because of the incidence of 1.228 per 100,000 the incidence, and it is slightly higher for the hemorrhagic strokes. Now, why do we actually need to know? Because of the clinical features, and most of the time it is quite varied, and we have less of suspicion, so that leads to delayed identification, and plus because of the opportunity that is there for an early intervention, if we actually delay the diagnosis, then you may miss out on the window for the reperfusion therapy, so which is an option what we call as a clot buster therapy. So if you present within the 4.5 hour window period, we can actually offer thrombolysis, which can probably salvage the penumbra or the area which is at risk. The other part about the strokes is that there is a 15 to 20% recurrence rate, which is within the 5 years of the index presentation. So if I have a stroke right now, then probably within the next 5 years, the recurrence risk will be between 15 to 20%, which is high, which will add to the burden with morbidity. So that is why you need to know and probably plan ahead. Quite different from adults in terms of the risk factors, where the adults will have mostly atherosclerotic disease, extracranial vis-a-vis and the intracranial atherosclerosis. In terms of the pediatric population, you will have various risk factors, which could be hematologic, which could be similar to what we have in adults, congenital heart diseases, dissections, which will actually have different treatment options. We look at arteriopathies, which are quite common in childhood. The other aspect that we need to know about is the mortality, which is nearly 6 to 10% in strokes. And we also need to now be aware about the options for acute treatment, which would be thrombolysis and thrombectomy, which is the mechanical thrombectomy. So the types that what we are looking at, you have arterial ischemic stroke, what we call as AIS, and then you actually have the hemorrhagic and the venous. So what we are looking at here is an arterial ischemic stroke. And if you can see this part here, it actually is slightly lighter compared to this part. So this is an early CT scan. So if we actually look at the early CT scan, what we are looking at, less than 3 hour window. But if you compare, so whatever you see on your left hand side is actually the right hand side. So you actually have this area where the gray white, which is seen on the left side, is not well seen. So this is what we call as loss of insular ribbon, and this is an early indicator of a stroke, but it is a slightly larger area. So whenever we look at an area which is more than 60% of the middle cerebral artery territory, yes, we can offer thrombolysis, but then the risk of bleed is also higher. Now this person actually did not underwent thrombectomy or mechanical thrombectomy or reperfusion, but you look at the scan now, and 24 hours later, you can actually see an extended lesion. So this is the actual infarct, which was visible after 24 hours. Now, if this was done probably on an MRI scan, you would probably be picking it up earlier. The other type is basically the venous sinus thrombosis. So what they can present is like an hemorrhage. They can actually have a midline shift, lot of edema. And when we look at the MRI, you can actually look at this part here where the superior sagittal sinus. The figure here will show you the different venous sinuses. So you have the superior sagittal sinus, the inferior sagittal sinus, straight sinus, transverse sinus. So all these other sinuses are visible, but the anterior part of the superior sagittal sinus is not visible. So this indicates that there is blockade, or what we call as a venous sinus thrombosis. And you are seeing the edema, the hemorrhage, and the midline shift secondary to the venous sinus thrombosis. The last part would be the hemorrhagic stroke. So typical scenario would be AVM, or arteriovenous malformation, or rupture of the aneurysm, and hypertensive bleed. So again, variety varies from a child vis-a-vis the adult. Adults will most likely have a hypertensive bleed, but in pediatric population, the reason for the bleed is different. So when you look at presentation, so the presentation would be any sort of focal neurological deficit, looking at hemiparesis, monoparesis, cranial nerve palsies, sensory impairment or sensory loss, new onset seizures. So again, you should be thinking about a seizure, when thinking about a stroke whenever you encounter a scenario where you have a new onset seizure. Acute headache, encephalopathy, unexplained, altered sensorium, could be directly loss of consciousness or even a comatose condition. Aphasia, ataxia, vertigo, fever. Now, why fever? Because the strokes that we see in a child could be more of within the infectious group. So you have tuberculous meningitis, you can have a focal cerebral arteriopathy following a short febrile illness, and that is the reason we look at these scenarios. So when to suspect or consider a stroke? So whenever we encounter an acute focal neurodeficit, speech change, a persistent change, or acute presentation of altered sensorium, new onset focal seizure, new onset severe headache, ataxia, non-specific dizziness, vertigo, difficult for a child to explain, but maybe you can actually just get the story that not walking well or maybe just spinning around. And someone where you can think of that maybe a history of maybe 2 hours ago did develop some weakness on one side of the body and was fully fine within the next half an hour. So this could be a transient ischemic attack. And to prevent the further recurrence, because the recurrences are high in the first 48 hours following a TIA-like situation. But we also need to be aware of stroke mimics, and imaging will definitely clear it out vis-a-vis the stroke versus the mimics. So again, we're looking at seizures, migraines, space-occupying lesions. In a typical scenario, nephrotic syndrome or people undergoing cancer chemotherapy, you can have PRES-like situation, metabolic stroke, hyperglycemia, hypoglycemia, drug toxicity in children who actually are again undergoing cancer chemotherapy, and infections per se. So when you look at the group of acute ischemic strokes, we are actually looking at the risk factors. So we look at hematologic disorders, sickle cell disease, polycythemia, arteriopathies, could be focal cerebral arteriopathy, moya disease, hypercoagulable states, so protein C, protein S, and thrombophilia profiles, so hyperhomocystinemia, cardiac causes, congenital heart disease, heart defects, infections, tuberculous meningitis, and a complication related to the vasculopathy, even with pyogenic meningitis, inflammatory conditions where you have vasculitis as a presenting feature or the group within the vasculitis, and drugs as a reason for the stroke presentation. So quite varied etiologies and hence quite different from an adult population. When we look at the territories, we actually are interested in where the deficit arises and what would be the expected recovery. So if you look at this figure here, see the area which is shown in blue is actually the anterior cerebral artery, orange color would be the middle cerebral artery, the yellow would be the posterior cerebral artery. So this is an axial view, this is a sagittal view, which is the midline sag where you can see the corpus callosum, and here you can see the lateral view where the lateral surface is mostly by the middle cerebral artery. And these are the vessels. So you have the circle of Willis, so which is formed by the anterior circulation and the posterior circulation. The main vessels in the anterior circulations are the internal internal carotid arteries, and the posterior circulation is formed by the two vertebral arteries joining to form the basilar artery, and the basilar artery ending into the posterior cerebral arteries. There is a posterior communicating artery which communicates with the anterior circulation. So if I have a block, the posterior circulation can feed into the anterior circulation if the block is a level below the communication. So the circle of Willis sometimes actually helps a patient. And when we do a DSA, what we call as a digital subtraction angiography, we can understand the blood flow in real time and really plan whether the intervention is required or not required. So whenever we see a child who actually has a stroke-like situation and we are going to think about an acute ischemic stroke, one thing is about to actually do the NIH or the National Institute of Health score, which is the stroke scale. And you actually now have got 42 points, so a higher score. So a severe score, a stroke would be between 21 and 42, which means that it definitely is looking at a larger area. A higher NIH score may mean that when I'm planning for my reperfusion therapies, I may actually do more harm and probably the risk of bleeding would be higher. The same would be at a higher score would indicate that I'm at a higher risk for the complications for the stroke. So which means that within the first 96 hours after the stroke, there is a higher chance of brain swelling or edema. and you may need to plan for decompressive surgery. So all these things start right at the moment you're seeing the patient in the ER or maybe in the casualty. Now, how do we actually assess as a child? So NIH primarily would be more focused for a adult world. But when we look at a child, we're looking at the FAST-S score, what we are looking at. So originally it was only the FAST. So we had the face, so we're looking at the asymmetry. So when the child cries, or probably there is a clear asymmetry when they're smiling, then that is one aspect. Ask them to elevate their arms and hold it at 90 degrees if they are sitting, and if they are lying down, maybe at 45 degrees. And if there is a drift, then we say that yes, you have weakness on one side. Ask them to probably speak if the child is able to speak. So this also requires some degree of cooperation from the child, which may be evident beyond the age of 2 years. Now, time here is of essence because we want to not miss the therapeutic window. So for the rapid intervention, you should actually make your diagnosis within that 4.5 hour of window that is available for instituting reperfusion therapy. S was added later on because that is basically now what we call as seizure onset. Because if I add S to this acronym of FAST, my probability of not missing out on a stroke actually goes higher. So I'm more confident as a clinical suspicion that if all these features, probably I should be thinking of a stroke. And retrospective studies have shown that if you use the FAST-S, you are actually going to pick up strokes 90-95% of the times. The other thing that we actually look for is B fast. So again, the fast, but something added prior to it, which is B and E. So primarily looking at the balance and looking at the eyes. So if you are aware of these things, you can probably pick up stroke and be suspicious about that episode very early on in the presentation. So what investigations we actually are looking for? So we're looking for simple blood test, peripheral smear, because we may pick up sickling here, metabolic stroke, so blood sugars, and to complete the whole thing, liver function test and renal function test. Thrombophilia profile plus hemoglobin electrophoresis in the right setting, homocysteine levels, cardiac evaluation, toxicology if the story is suspicious from that perspective, and a lipid profile including a lipoproteinase. So this is what we would do from the blood parameters. But when we actually look at the radiology, it all depends on what is available at that time. So if we are looking at CT scan, then yes, you can do a CT along with a CT angio to look for the blood vessels. If an MRI is feasible, probably we do an MRI brain with an angiography. You can do a rapid MRI wherein we just do something what is known as a stroke protocol. So we do what we call as a diffusion weighted imaging, an ADC map, and we just do a flare study and the angiography. Now with the rapid assessment, what we actually look for a diffusion flare mismatch. What we are meaning by that, area which is already showing abnormality on the diffusion study is not showing abnormality on the flare or the T2 weighted sequence, then the penumbra is still there and we can salvage that by proceeding with the reperfusion strategies. If the setting is right and you have the technique, you can do a perfusion map, which could be a perfusion study on an MR or a perfusion on the CT. But be aware that all these additional procedures do take time. So if time is of essence, probably just do a CT angio or MR angio with a rapid screen. You can be absolutely certain because the MR may also pick up on other things which may be missed on by the CT scan. So MR would always be more valued in a stroke setting. Now we do also have this artificial intelligence. So we actually calculate the infarct volume and the area at risk, and we use the data from the diffusion weighted imaging and the perfusion scan and identify this area and plan the strategies which will now be translated to the pediatric world as well. So what we are looking, so just to give you an example, so if you look at this image B, so image B is showing where you cannot really pick out other than that the insular ribbon is probably lost. So it means that there is an MCA territory stroke. But if you do the perfusion map, the A figure shows that it's a very large perfusion gap. But when you do a perfusion study, maybe later on, what you can see is that, yes, the area has narrowed, but the other side also is showing some abnormality. And 24 hours later, the final area. So if you look at the final infarct volume, you can actually notice that it is smaller in size compared to the actual perfusion deficit, which was seen on the earlier one, which means that they have been salvaging some part, but what was missed on the other side is probably the other stroke, which also would be equally damaging. So these two territories will also give you the etiology, because you're looking at the right side as well as, sorry, right side and the left side, and you may probably looking at a cardiac source. So this imaging may also give you a source for the stroke. So what is acute care? So again, airway, breathing, circulation, primary management, that is for sure, manage the seizure. Hypertension, if it is on the higher side, we need to lower it to maintain an optimal cerebral perfusion pressure, and then plan for penumbra rescue, which is the primary aim, because I want to restrict or limit the area of injury, which is with the reperfusion. Now, with the adult world, everyone is geared, because most of the time, a child who comes to a hospital will be beyond the actual 6-hour window. So reperfusion is not very easily available or planned or seen in a pediatric situation. But as we move on, as the awareness improves, we probably can plan for reperfusion therapies even in children. And then we look at thrombectomy, and then we actually try to identify an etiology, and then place your strategy so that we prevent the recurrences. And at the same time, if your initial MRI shows that, yes, it was a large volume infarct, then we also discuss the decompressive craniectomy at the same time. So three scenarios that you may actually encounter, because the treatment options are different for. So one would be arterial dissection, cardioembolic stroke, and the other causes. So the treatment options vary for each. So you need to identify the etiology, because if it is dissection, then you're going to look at low molecular weight heparin and oral anticoagulants for 6 to 12 weeks. If you're looking at cardioembolic stroke, again, the same option, but the duration of therapy is going to change. And in these two settings, we do not use antiplatelet therapy. So hence the importance in trying to identify a cause. Dissections will be picked up by the vascular imaging, and a cardioembolic source will be picked up by the 2D echo. So everything on day one. But in an ideal world, most of them receive aspirin on day one. By the time all these information is available, then we probably go to a dedicated group where I would want to use anticoagulants, or do I just stick to antiplatelet therapy? So if it is an antiplatelet therapy, depending on the other causes, whether it be arteriopathy, vasculitis, then we probably look at use of aspirin. Again, there is no definitive endpoint, but we'll be probably looking at 1 to 2 years, trying to identify the cause, and then understand whether the recurrence risk is higher, and then plan the duration of therapy. If you have arteriopathy of the moya variety, then look at revascularization therapies, revascularization surgeries. Ongoing care. So once you have identified, and then you probably are in the hospital, all the acute phases passed away, you are in the maybe the 5th day, 6th day, then what we are actually looking at? We're assessing the swallowing function, we're assessing the hydration, nutrition aspect, because yes, if you have a stroke, you are slightly altered, you are on medications, you may not be eating well, the area which is involved may actually be impairing the swallow, so you may look at feeding strategies, monitor the pain, and actually identify pain, and appropriate pain relief measures should be instituted. Keep on reassessing the motor function, plan for rehabilitation, definitely look at vision and hearing, will have an impact for a child in the long run. Now, what is important is that if you actually see a child with at an earlier age, so it all depends, or the motor function depends on your developmental status. So at what age you are actually seeing the child, because some functions will evolve over time. So the prognostication depends on, let's say a child is at 4 months and you actually have a scenario like, but then by that time the lower limb function, the upper limb function would not have evolved to the normal status. So you will probably need to monitor them ongoing to see whether actually there is a deficit which is evolving, and what steps need to be taken to actually help him for rehabilitation. Look for sensory system, because sensory losses may actually again have implications from the developmental profile, and sleep is what we really focus on. Adequate sleep, so that also makes things easier for the child. Now, looking at the first case, a 6-year-old boy, new onset seizure, right-sided weakness, aphasia. So what we are looking at, so this is the diffusion weighted image, and what you can see is a bright signal which is coming through. This is on your left-hand side, involving the inferior frontal gyrus, which is the Broca's area. The same map on the other side, this is the ADC map. For an acute stroke, the brightness on the DWI is reflected by darkness on the ADC map. Then we say that this is an acute or a hyperacute stroke. And because old strokes will also appear bright on DWI and nothing will be reflected on the opposite side. So this is what we would say as a left MCA territory infarct or left middle cerebral artery territory infarct. And now we will have to find out the cause. So the angio gives the answer. So this is the posterior circulation, which is well formed, but look at the anterior circulation, and there is an abrupt cutoff here. And you can see that this, these are the internal carotids. This is the vertebral, this is the basilar. Look at the caliber of the basilar, look at the caliber of the internal carotids, and you can see that there is a variation here, and there is a cutoff, and all these blood vessels, which we call as the, these are the ones which actually are the collaterals which are developed because of the blockade of the supraclinoid ICA. So the answer here is a Moya-Moya disease, and we will have to then plan for revascularization surgeries in future. So revascularization was done for this child. It was also done for the opposite side, even though it was not asymptomatic, but in stages, and it continues to do well. So the first incident was in 2016, and now there is no deficit as of today. Now, I'll talk about one adult one which we did, because this is the procedure that is quite commonly done in an adult world. So a 42-year-old gentleman had presented with Broca's or aphasia and weakness, clinically left MCA territory infarct. And this is the angiogram, which is the digital subtraction angiogram. And you can see that this is the anterior cerebral artery. But there usually is something here, which is the middle cerebral artery, but we cannot see anything. So after giving the IV thrombolysis, which is what we call as alteplase or tenecteplase, depending on the weight, you use the dose. And then we actually try to do a mechanical thrombectomy, which means that you insert a guide wire and try to actually suck out the thrombotic or the embolic material which is there. During the procedure, we can see that it has now opened up, but not completely. And there is some degree of material here left as well. But finally, eventually, after 2 or 3 settings, you can see that everything has opened up. So now what we can see is that this is the middle cerebral artery, which is now finely filled. This image is actually a sagittal view. This is an end-on view. But what we can see now is that the ophthalmic artery is also well formed. This is the middle cerebral artery, and then you have 2 divisions, the superior division and the inferior division. This is the one which actually is not still well seen. So usually middle cerebral artery has 10 branches, 5 in the superior division, 5 in the inferior division. And the deficit eventually was limited only to the aphasia, which also has recovered over the past 1 month. So this was just done last month. So scenario which will definitely, a large MCA infarct having no residual injury because of the thrombectomy, the precentral and the procentral vessels opened up, your motor cortex was spared, and you actually are doing a good job. Now we come to the venous sinus thrombosis. So this essentially is thrombosis of the cortical or the deep venous sinuses, can manifest with hemorrhage, venous infarcts, headaches, seizures, altered sensorium. Everything will be part of the presentation. So again, the same thing which we showed in the first one, you are seeing a CT scan which is showing a hemorrhagic focus here, midline shift, which probably may require decompression. So the usual presentation is with headache, cranial nerve crisis, seizures, encephalopathy, focal deficits. And when we actually look at the risk factors, primarily thrombophobia is what we really look at. Again, the medications, infections, very common cause, ENT group of infections can lead to spread of the infection and vasculopathy, leading to the thrombosis. Again, autoimmune conditions like SLE, inflammatory bowel disease, have a very high risk of venous sinus thrombosis. So if you have this story of ulcerative colitis or Crohn's disease, you can actually probably have an idea about the etiology as well. And then you can have this as a part of nephrotics, dehydration, malignancy, sickle cell anemia, and sometimes even with closed head injuries. So focus will be control of seizures, adequate hydration. If we think that hydration is one of the factors here. For infection part, antibiotics, monitor the intracranial hypertension, fundoscopy, look for the imaging, look for midline shift, and plan ahead, maybe requiring decompression. But the mainstay will be oral and injectable anticoagulation. And in certain settings where we are not finding any change within 24 to 48 hours, we may plan for intravenous thrombolysis. So we usually do it by guiding the catheter towards the venous sinuses, and we inject urokinase directly into the venous sinus to break open the clot. So a 14-year-old boy had mild fever for 4 days, headaches, and then suddenly encephalopathic, one episode of seizure prior to hospitalization. So what we are seeing here is his MRI, which is showing, so this is the thalamus, this is the caudate. You can see some swelling here, and you can see this bright line as well as black areas within the thalamus. So you can see a prominent vessel here. So this is the vessel, this is the straight sinus, and then you can actually see some branching vessels here. And we actually did an intracranial venography, and we can see the superior sagittal sinus, but nothing within the deep system. So again, to remind ourselves that usually, so this particular superior sagittal sinus is well formed, nothing for the inferior sagittal sinus or the internal cerebral vein. So this is classically a deep venous sinus thrombosis. The treatment options remain the same. Mortality rate is slightly higher for this particular setting, but luckily for us, the child did do well. Now, hemorrhagic stroke. So again, the same sort of presentation in terms of the, but it's just the imaging that will give you whether it is an ischemic stroke or a hemorrhagic stroke. So we have vascular factors, we have clotting disorders, and we have within the vascular factors, we have arteriovenous malformations, aneurysm, moya disease can present as hemorrhagic strokes, and cavernomas are known to bleed as well as have seizures. For the clotting disorders, we're looking at bleeding tendencies, vitamin K deficiencies, platelet dysfunction, and actually people who are on anticoagulation for, let's say, some other reason, and they tend to have a very high INR and then they bleed, and that is the reason for the hemorrhagic stroke. Or in a right setting, again, drugs, we're looking at amphetamines and cocaine, not so common in our setting, but the vascular factors and clotting disorders are the common factors that we see for a hemorrhagic stroke. So again, we look at medical management, which will include the ABC of the emergency care, plus trying to look at control of the seizures, hypertension, and any other medical scenario that may be relevant for that particular case. Within the two main vascular factors, you have endovascular treatment or surgery. So even if it is an arteriovenous malformation, you would actually look at providing the support by either embolizing the with glue, actually making the vessels or that nidus actually disappear, or you can actually remove the AVM surgically, or you can actually with the endovascular treatment insert coils. So same thing applies for aneurysm. And for the other causes where the bleeding tendency is higher, if the case requires, you may want to actually correct the bleeding tendency by using a lot of FFPs, reversal of the vitamin K deficiencies, and then reversal of the anticoagulation. If we are on now newer oral anticoagulants, which is a different setting, because for the warfarin, you can actually reverse it quite easily. But for the newer anticoagulants, you may find it very difficult to reverse. So we use prothrombin complex concentrates. We have something which is known as Praxbind. So this is the brand available, and that actually helps us to prevent the bleeding resulting from newer anticoagulants. And radiosurgery, again, looking for options other than open surgery. So this is where we are for the stereotactic surgery and the treatment. So we have arterial ischemic strokes, we have the venous sinus thrombosis, and the hemorrhagic strokes. So in summary, what I would like to just highlight is we always need to keep a low threshold for a diagnosis of stroke in children, because an incidence of up to 8 in maximum setting per 100,000 children. Remember the acronym FAST, FAST-S, and Be Fast. Also remember that the varied risk factors for stroke in children indicate that the treatment options are slightly different, but reperfusion strategies are also similarly available for children. General medical care and intensive care primarily before you move on to the reperfusion strategies. For acute ischemic stroke, either we look at oral anticoagulation, low molecular weight heparins. If dissection and cardioembolic strokes are ruled out, then aspirin is the mainstay, which will go on for a year or two. For venous sinus thrombosis, again, anticoagulation need not document the opening of the sinuses, which means that no scan required after the completion of therapy, but we are again looking at 3 to 6 months of treatment. And remember, for the endovascular or surgical interventions for hemorrhagic strokes, and then we take help of the neurosurgeons or the interventional neuroradiologists or interventional radiologists to carry out the endovascular treatment. Thank you.
Thank you so much, sir. We have a couple of questions. The first question is, what is the first radiological investigation to be done in acute ischemic stroke, and what is the gold standard investigation?
The ideal setting will be an MRI of the brain, and because of the rapidity, it will be a stroke protocol MRI, which means that it will be just including the sequences of diffusion weighted imaging, ADC map, a flare, and the angio. It takes around 12 to 15 minutes to carry out this, and you are not actually losing out any time for it. And gold standard is always the MRI.
So the next question is, in venous sinus thrombosis with hemorrhagic transformation, how to use anticoagulants?
Yeah, so there's a lot of hue and cry about already present bleeding. If I anticoagulate, I may actually do more harm than benefit, but that is not the case. Even with bleeding visible on the scan, you should be anticoagulating, and all of the studies have shown that you do not worsen the outcome even in a hemorrhagic transformation.
And the last question, sir, how is there any role of anti-epileptic drugs, and if yes, how long they need to be continued?
And yes, during the acute phase for a stroke, if there has been a seizure, you would be. If for prophylactic use, there is no role of actually the anti-seizure medication, and the principles for someone who actually has had a seizure remains the same for withdrawal as with any other child who has had a symptomatic seizure.
Okay, thank you, sir. We don't have any more questions, I think. Shall we conclude the session, sir?
Yeah.
Yeah. Thank you, sir. Thank you so much. Our next speaker is Dr. Vilas Jadhav, Director and Consultant Pediatric Neurologist, Arya Children's Super Speciality Clinic, Kolhapur. His area of interest is pediatric epilepsy. Sir will be talking about pediatric movement disorders. Over to you, sir.
My slides are visible?
Yes, ma'am.
Yeah. So good afternoon, everybody, and thank you, committee, for giving me this opportunity. I'll be talking on anti-epileptic drugs and relevant newer advances in today's session. So to know briefly about all these newer anti-epileptic drugs, we'll keep the objective first to compare the advantages of new anti-epileptic drug over old standard anti-epileptic, to understand the different mechanisms of action of anti-epileptic drugs, and to know the current ongoing research which may be the new future for anti-epileptic drugs henceforth. So the ideal anti-epileptic drug should have following characteristic: a very good efficacy, that there should be a good seizure control after starting anti-epileptic drug. The side effects should be minimal, so that there will not be any problem in day-to-day life of a patient. Easy dosing scheduling makes it comfortable for the patient. The drug should have minimal drug interactions, and expenses should not be so much that it will prohibit the patient from taking the anti-epileptic drugs. And it should also maximize the quality of life. But unfortunately, even if you consider the older anti-epileptic drugs or a newer or recent anti-epileptic drugs, all these characteristics are not seen in a single drug. In a journey of anti-epileptic drugs, which started in 1857 with the discovery of bromides, so many other new drugs have been added stepwise. So initially, bromide, phenobarbital were the old generation drugs, and then there was addition in first generation series was phenytoin, acetazolamide, corticosteroids. The main revolution occurred when second generation drugs came, and that is around in 1970s. Most of the drugs are still in practice, and we all of us are using this widely. So clobazam, clonazepam, like all these are diazepam derivatives, valproate, carbamazepine, and chlordiazepoxide. The main revolution happened very rapidly after that, and now we have the third generation anti-epileptic drugs. So before 1993, the drugs which were in use were carbamazepine, clonazepam, diazepam, lorazepam, most of like predominantly diazepam derivatives, along with phenobarb, phenytoin. While in up to 2005, new drugs came in picture, which are called as second generation. The current and latest anti-epileptic drugs are rufinamide, stiripentol, rivracetam, lacosamide, perampanel, and reticapine. So why there is always need for new development or new research in anti-epileptic drugs? Because most of the old generation anti-epileptic drugs have several side effects. They have endocrine and metabolic side effects and affection on bone. So phenobarbital, phenytoin, carbamazepine, oxcarbazepine, and valproate all have this effect causing osteomalacia. They may have affection of folate metabolism causing teratogenesis and anemia, like the drugs phenobarbital, phenytoin again, and valproate predominantly. They may have altered connective tissue metabolism or growth, causing facial coarsening, hirsutism, gingival hyperplasia, and contractures, predominantly seen with phenytoin. Some neurological symptoms, again predominantly seen with phenytoin, rashes, and Stevens-Johnson syndrome seen mainly with lamotrigine and carbamazepine. Apart from these side effects, the older drugs also have some added benefits. For example, lamotrigine, even though like we are getting rash, it requires slow titration, but it has minimal teratogenic potential and so can be used during pregnancy or childbearing age. Oxcarb and carbamazepine are at risk to cause hyponatremia, osteoporosis, drug-to-drug interactions, but can be rapidly titrated and they are mood stabilizer. So those children with behavioral disorder who are coming with epilepsy, these drugs can be preferred. So topiramate may cause weight loss, nephrolithiasis, cognitive slowing, and also needs a very slow titration, but definitely can be considered in a child who is obese, can be used as a migraine prophylaxis, can be used in neuropathic pain. So these added advantages are there with topiramate. Similarly, valproic acid is a drug which we can, along with epilepsy, can use in migraine prophylaxis and can be used as a mood stabilizer. But the considerable side effects are weight gain, thrombocytopenia, hepatotoxicity, pancreatitis, and PCOD. So should not be used in the childbearing use and in adolescents. So what are the advantages of newer anti-epileptic drugs, which are third generation? So these drugs are have greater tolerability, few side effects, few drug interactions, lower rate of relapse once we withdraw, fewer idiosyncratic reactions, and minimal influence on metabolic pathways. It is very important to know how most of these anti-epileptic drugs they work, because the selection of anti-epileptic drugs and the side effect profile as well as the metabolism causes lots of influence on the dosing pattern and the side effects. So the commonest mechanism of action is sodium channel blockade, and it's a big group. So carbamazepine, oxcarbazepine, and the latest eslicarbazepine, along with felbamate, lamotrigine, phenytoin, rufinamide, topiramate, and zonisamide comes under the sodium channel blockers. Followed by that, the other important mechanism is potentiation of the GABA activity, and the drugs which are grouped under this are barbiturates, felbamate, tigabine, topiramate, valproate, and vigabatrin. Now, calcium channel blocker and potassium channel, those drugs which act on potassium channel are very less. And among calcium channel blockade, main is ethosuximide, while lamotrigine and zonisamide has the added mechanism of action of calcium blockade. So they have certain role in absence seizures along with ethosuximide. The latest drugs like levetiracetam, gabapentin, pregabalin has little different mechanism of action. Antagonism of glutamate is the main mechanism in felbamate, lamotrigine, and topiramate. This is a very good article which gives us update on anti-epileptic drugs, and this is basically a continuum. This is an update which is published in February 2016 on the epilepsy issue of continuum, and also audio interview available of this particular article, which gives details of almost all second generation and third generation anticonvulsant in detail. So coming to the individual anticonvulsant, first we'll consider the group which has sodium channel blockade. And in this particular group, the latest introduced drugs are lacosamide, rufinamide, zonisamide. So coming to lacosamide is effective in focal seizures, and mechanism of action is through inactivation of sodium channel. Metabolism is predominantly hepatic, while 40% is eliminated unchanged in urine. T-half is 13 hours, so the twice weekly dosaging is required. Starting dose is 4 to 12 milligram per kg per day. Maximum we can go up to 20 milligram per kg per day. Like other anticonvulsant, old or new, this also has side effects like dizziness, headache, nausea, vomiting, very commonly seen. But important side effect to remember that at higher dosage, lacosamide causes dose-dependent prolongation of PR interval. So those children who have been started on lacosamide should be regularly screened at least every 3 months with the ECG if the child is on high dose. The important indication is this can be used as a monotherapy as well as adjunctive therapy in focal seizures. It may show a greater efficacy when it is combined with other drug which also has a sodium channel blocking mechanism. So from this sodium channel blocking group, we can use any other drug in combination, and that will improve the efficacy. In zonisamide is structurally little similar to sulfonamide, and it is broad spectrum. The mechanism is apart from sodium channel blockade, it also have T-type calcium channel action and inhibition of carbonic anhydrase activity, which makes it little broad spectrum. Important point to be noted in metabolism is its T-half is very long, 60 hours. So even if like any dose is missed, there will not be any breakthrough seizure, and this 60 hours T-half can be used for the dosing, which is not every day, or you can use alternate day dose. So dose is 1 mg per kg per day as a starting, usually 4 to 8 milligram, maximum up to 12 milligram per kg. Adverse events like sedation, ataxia, dizziness, nausea, and fatigue are seen commonly. Less commonly, weight loss, rashes, and Stevens-Johnson syndrome. Renal stones, oligohydrosis, and hyperthermia, along with metabolic acidosis, occurs rarely but are seen more commonly in children as compared to the adult. This is also indicated as adjunctive therapy in focal seizures, and zonisamide usually is used as an adjunctive and not as a monotherapy because of the cognitive adverse events. Eslicarbazepine is a third generation prodrug of carbamazepine and oxcarbazepine. It has active metabolite, that is S-licarbazepine, and hence the name is eslicarbazepine. Mechanism of action again through sodium channel blockade, and the main metabolism is hepatic. But it also has a renal excretion. Around 50% of it is excreted in urine. It is a weak inducer of CYP3A4. So it potentially decreases the plasma concentration of estrogen and increases the plasma concentration of phenytoin. So it has to be used very cautiously when is used along with the phenytoin. Starting dose is 10 to 20 milligram per kg. Maximum we can go up to 20 to 60 milligram per kg. Among side effects, we should remember mainly the rashes and dizziness. Rashes are less commonly reported as compared to the oxcarbazepine with eslicarbazepine. So this is the added advantage over oxcarbazepine. And it is also used as an adjunctive treatment for focal seizure. But a very important point to remember over here is it should be avoided in idiopathic generalized epilepsies. Rufinamide again is a sodium channel blocker, and main metabolism is renal. So should be used cautiously in patients with affection of kidneys. It is also an enzyme inducer, and the important drug interaction to remember with rufinamide is valproate decreases rufinamide clearance and increases rufinamide levels up to 70%. So should be cautiously used when used with valproate. The important adverse event to remember is shortening of QT interval, and regular monitoring with ECG is required during the treatment. It is used as an adjunctive treatment for seizure associated with LGS. The certain newer derivatives of levetiracetam, they function through synaptic vesicle protein 2A stimulation, and this is brivaracetam is the latest molecule which now is in practice, and mechanism of action is binding to SV2A receptors. Predominant renal excretion, so should be used cautiously in children with kidney disorders. Starting dose is 1 to 2 milligram per kg per day, and in pediatric patients who are more than 50 kg, initial dose can be 50 to 100 milligram, going up to maximum of 200 milligram in a day. The adverse reactions are somnolence, dizziness, fatigue, and irritability. What is more important with brivaracetam, even though the adverse reactions related to levetiracetam are not so commonly seen with brivaracetam, but there are like many drug interactions which are seen. So we have to be very careful. Brivaracetam is not effective when added with levetiracetam. So if you want to start brivaracetam, it is always better to omit levetiracetam. Approximately 20-fold higher affinity it has, and greater selectivity and higher brain permeability as compared to levetiracetam, which is an added advantage. And the clearance is usually increased by enzyme inducers, so should be used very cautiously with other enzyme inducer drugs. Those drugs which work through AMPA receptors are the latest is perampanel. The mechanism of action is selective non-competitive AMPA glutamate receptor antagonist. The main metabolism is through hepatic excretion. Adverse event are dizziness, somnolence, headache, fatigue. But very important one to remember is aggression and behavioral changes. especially in those children who has intellectual disability. It's a good drug for focal seizure. It can be used as adjunctive as well as monotherapy. It can also be used in primary GTCs. And although it's not FDA approved indication for myoclonic seizures, but several case reports in literature mention that it has a good efficacy in progressive myoclonic epilepsies. Other drugs which work through GABA action are gabapentin, pregabalin, vigabatrin, tigabin. So out of this, we will discuss vigabatrin in detail. Just going briefly through this table about gabapentin and tigabin is few points to remember is one, renal excretion. Second is they are enzyme inducers. Dizziness is a more common side effect. And these patients may are at risk for syndrome like DRESS. So drug rash with eosinophilia syndrome. Coming to vigabatrin, let's discuss a bit in detail. So mechanism of action is irreversible inhibition of GABA transaminase resulting in accumulation of GABA. Main metabolism is renal excretion. It may worsen absence and myoclonic seizures in idiopathic generalized epilepsy. So has to be used carefully in patients suffering from this. The main adverse reaction apart from common sedation, fatigue and dizziness is progressive and permanent bilateral concentric visual field constriction, which may be seen in up to 30 to 40% of individual, and usually it is dose and duration dependent. It is adjunctive therapy useful in infantile spasm, especially related to tuberous sclerosis disease. Cannabidiol, the main mechanism of action is enhancing GABA activity through allosteric modulation of GABA receptors. Metabolism is mainly hepatic. Initial dose is 5 mg per kg, but can be stepped up gradually to 10 mg per kg in 2 divided dosages. Most common side effects is mainly sedation and fatigue with decreased appetite and diarrhea. Along with clobazam, it increases the concentration of active metabolite of clobazam, that is N-desmethyl clobazam, and should be used very cautiously. It may produce increase in liver enzymes, and total bilirubin level need monitoring when a child is on cannabidiol, and the monitoring has to be done from before treatment to 1, 3 and 6 months after initiation of treatment. The important indication of cannabidiol is LGS and Dravet syndrome in patients above 2 years. CD-pentol is approved in Europe in 2001, but still has a label of orphan drug. Mechanism of action is mainly through GABA, and it is a hepatic enzyme inducer. Renal metabolism is the main way of excretion. Dose is 50 milligram, roughly.
Sorry to interrupt you, ma'am.
Yes.
Could you please conclude in the next 5 minutes?
Yes.
Thank you, ma'am.
So the adverse events are mainly anorexia, and it is indicated in the seizures associated with Dravet and clobazam. Ezogabine or retigabine is mainly the potassium channel drug, and the therapeutic uses are mainly as an adjunctive therapy to refractory partial onset seizures. This is a reference article for anti-epileptic drugs development which are in pipeline, and most of these drugs are novel agents. They are either anti-inflammatory like belnacacin, pro-drug like valproic acid, chloride importer blockade like bumetanide, drug acting on potassium channels are YKP3089, ICA 105665. Melatonin has a good anti-epileptic effect, and 5-HT receptor agonists like naltrexone. So most of these drugs, especially apart from these drugs, some glucose derivative like deoxy-D-glucose, they are still under research, and I will not go into details of these. Just to narrate few, fluorophilbamate, ganaxolone, JZP4, a derivative of levetiracetam, that is telitiracetam, YKP3089, charisma some AMPA antagonists like NS1209 and BGG492, CPP115, valrosimide are the new drugs which are still in research and in pipeline to come or get FDA approval as a newer anti-epileptic drugs. There are certain endogenous neuropeptides like somatostatin and neuropeptide Y has shown a very good potential and promise to be used as a anti-epileptics. So to summarize, when we are selecting newer anti-epileptic drug for different type of epilepsies, focal seizures, usually most of these drugs are very efficacious and effective in focal seizures. In primary GTCs, topiramate, lamotrigine, and levetiracetam are mainly effective. Absence, apart from ethosuximide, in latest generation, lamotrigine can be helpful. Levetiracetam, though has a similar mechanism of action through calcium channel, but to be used incautiously because it may aggravate absence seizures. In myoclonic, the main indication is topiramate and vigabatrin. In epileptic spasm, topiramate, lamotrigine, rufinamide, and vigabatrin are important. Drugs to be avoided in certain type of seizures. The gabapentin has to be avoided in absence seizures, myoclonic seizures, and LGS. Topiramate is a broad spectrum and can be used in most of the type of seizures. Lamotrigine should be avoided in Beck's, LGS, JME, and myoclonic seizures. And vigabatrin should primarily used in focal seizures along with tuberous sclerosis, but should be avoided in most of the other type of seizures. So to conclude, the newer anti-epileptic drugs are better, but not always superior to conventional AEDs. Many AEDs are available for the treatment of epilepsy with specific advantages and disadvantages. Some AEDs have additional efficacy in the treatment of comorbidities such as migraine or bipolar disorder. Considerations in AED choice include the AED's efficacy profile as well as the patient-specific factors. And AED combination should avoid unfavorable pharmacokinetics and pharmacodynamic interaction. So these are two articles which I'll recommend. One is from Journal of Neurology, which gives the practice guideline updated summary, efficacy and tolerability of new anti-epileptic drugs in new onset epilepsy. And the second very good article is from Annals of Pediatrics, and this is on the newer anti-epileptic drugs. So with that, I'll conclude this session. Thank you very much.
Thank you so much, ma'am. Since we don't have any questions in the chat box, shall we please conclude the session, ma'am?
Yeah.
Thank you so much, ma'am. So moving ahead with the last session for today. Last session is a panel discussion on some dilemmas in pediatric neurology. We have Dr. Debangana Barua and Dr. Shreyasi Biswas presenting one case each. Our panelists are Dr. Neeta Naik ma'am, consultant child neurologist and developmental pediatrician, director and in charge of N1 Neuroscience Center. Her areas of interest are childhood epilepsy and neurodevelopmental disorders. Coming to our first panelist again, Dr. Neeta Naik ma'am, consultant child neurologist and developmental pediatrician, director and in charge of N1 Neuroscience Center. Her areas of interest are childhood epilepsy and neurodevelopmental disorders. Our other panelists are Dr. Mona Gazre ma'am, Dr. Shekhar Patil sir, and Dr. Arpita Adhikari ma'am. The cases will be presented by the Neuro Fellows. The first case by Dr. Debangana Barua.
Is there any disturbance? I can't hear her. I can't hear you.
Yes, ma'am. We're sorting it out.
Okay, sorry, sir.
Okay. The first case is a 6-year-old female child born of non-consanguineous marriage with normal birth and development. She came to us with complaints of multiple episodes of paroxysmal events since the last 30 days. These events were in the form of focal dystonic seizures, predominantly of the right upper limb, with phase lasting for 1 to 2 minutes. Occasionally, on the left side was also involved. Initially, it was 1 to 2 episodes per week, which had now increased to 5 to 6 episodes per day for the last 10 days. History of episodic behavioral changes like aggression, shouting, and inconsolable cry was also present since the last 15 days. There is no past history of seizures and no significant family history is present. For these above complaints, the child had shown to multiple doctors and she came with investigations. Following investigations were done before she came to us to our OPD. EEG done was suggestive of left hemispheric epileptiform discharges. MRI done thrice was normal. The child was started on oxcarbamazepine, then clobazam and valproate, but no clinical improvement was noted. On examination, vitals were stable. CNS examination, higher mental function, the child was encephalopathic with GCS of 11/15, and the child was drowsy and disoriented. Cranial nerves were normal. Motor system was also normal, and episodes of dystonic seizures of the upper limb with face, predominantly on the right side, was present, and there was no meningeal signs. In the video, we can see there is a dystonic posturing of the right hand upper limb, which as well face is also involved. So we made a clinical summary. A 6-year-old female child born of non-consanguineous marriage with normal birth and development, with subacute onset of focal dystonic seizures, predominantly of the right upper limb with face, with encephalopathy and neuropsychiatric symptoms. So my first question is to Dr. Neeta Nayak, ma'am. What could be the possible differential diagnosis for this case?
It's quite an interesting case because of the polysymptomatology, what is present in the child. Obviously, the type of seizures can be called as spatiobrachial dystonic seizures, which you rarely see in pure benign epilepsies. In addition to that, some amount of encephalopathy, and you also said behavioral episodes. So obviously the most, and a progressive disorder, because you said that the child has been, the seizure severity and seizure frequency has also been increasing. So autoimmune encephalitis is the first most important diagnosis. CNS infections, I would not really think that it is likely to be CNS infections because of the fact that the child, you expect the child to deteriorate much more, except for say maybe tuberculous encephalitis, and in that case you won't get so much of focality and dystonic seizures are not known, but you can keep it always at the back of your mind because TBM can mimic anything. CNS vasculitis, again the encephalopathy and the behavioral change cannot be, encephalopathy you may explain, but not the behavioral change and the seizure semiology. So I think the first autoimmune encephalitis is the most likely diagnosis in this particular child.
Okay, thank you, ma'am. Next question is to Dr. Mona, ma'am. When to suspect a case of autoimmune encephalitis?
Yeah, thank you, Devangana. And as Neeta Nayak ma'am also pointed out that this child, and as you narrated in the case, this child has a polysymptomatology. So, we look at basically, as Madam rightly pointed out, that AI is the first diagnosis which comes to our mind, primarily because of the encephalopathy and behavioral changes. So these children can present, mostly we suspect them when there is an encephalopathy, and it could be varied encephalopathy right from decreased awareness to say mild coma or coma-like thing, and along with it, you have a cognitive slowing could be there present earlier. Now, coming to the behavioral or psychiatric features, that could be mood swings and more of positive symptomatology in terms of irritability, hyperactiveness, anger outbursts, etc. They also come with seizures. Predominantly, and it's always they can be resistant and drug resistant kind of seizures, so they're difficult to treat kind of seizures. They can be focal, generalized, etc. And movements, of course, forms a very important part of the differential diagnosis or when we suspect AIE. And again, varied type of movements, as we saw in this child, dystonia was a predominant one, but you could get others too.
Okay, thank you, ma'am. So my next question is to Dr. Arpita, ma'am. How to investigate a case of suspected autoimmune encephalitis?
Yes. So thanks, Debangna, for that question. A very good case. So when we are suspecting autoimmune encephalitis, we basically need to have the clinical picture first. Already Neeta Naik ma'am and Mona ma'am has said that it is polysymptomatic. You cannot pinpoint, you cannot localize. And the most important thing over here, I would say, is the neuroimaging. So in this child, the neuroimaging was done thrice and that was normal. So in this case of autoimmune encephalitis, you need to do a neuroimaging to exclude other diagnosis and not to pinpoint as autoimmune encephalitis, because in 50% of cases of autoimmune encephalitis, the neuroimaging is normal. So a child who has presented with neuropsychiatric symptoms, with seizures, with a normal neuroimaging, would definitely should be the antennae should be up towards the autoimmune encephalitis. In some cases of NMDR encephalitis, there would be limbic involvement. Some cases such as anti-DR2 basal ganglia would be involved. So a must investigation in any case would be an MRI brain with contrast, looking at the T2 and FLAIR images to see what is involved, and if the neuroimaging is normal, then autoimmune encephalitis should be considered. Regarding the EEG would not be normal. In most of the cases, it would be abnormal, but it would be some non-specific like focal or generalized epileptiform discharges. In NMDR encephalitis, you get a delta brush pattern, which will be present in NMDR. Regarding CSF, so yes, in CSF, to differentiate in between the autoimmune and the infectious encephalitis, you need to look at lymphocytosis. So in autoimmune, you will get milder CSF pleocytosis, whereas in infectious, you would get more lymphocytic pleocytosis. The CSF neopterin is one for autoimmune, but it is not that available. Your CBC, your ESR, CRP, and ferritin will not be that risen in autoimmune encephalitis. Antibodies, these are the most important to give a definitive diagnosis. Although 50% of autoimmune encephalitis can be antibody negative, but it is important to pinpoint the antibody and which autoimmune encephalitis it is to prognosticate as well as for treatment. So a serum as well as CSF antibody level is important. CSF is extremely important for anti-NMD encephalitis because the sensitivity is 100% in CSF and 85% in serum. Rest all can be tested even in the serum. When we are doing the antibody testing, it is very important to know whether the child is already on treatment or so. Because in a resource constraint, empirically people do start with steroids, which needs to be started if there is non-availability. So CSF needs to be collected and extra CSF needs to be there. And in case the treatment is started, then not to rely on serum, but CSF needs to be done to rule out that it is positive or negative encephalitis.
Okay, thank you, ma'am. So in our case, routine blood investigation said was normal. Child CSF showed 8 cells with lymphocytic predominance, and proteins and sugars were normal. Antibody panel for autoimmune encephalitis was negative. So a diagnosis of possible autoimmune encephalitis was made. So my next question is to Dr. Shekhar Patil, sir. How to manage a case of autoimmune encephalitis?
Yeah. So we have seen that the antibody panel is negative, but as rightly pointed out by Arpita, Nearly 50% of all the cases would actually turn up as negative. So if your clinical pattern, so we are primarily interested in the clinical pattern, and if clinical pattern is supportive of your clinical impression of autoimmune encephalitis, you should, regardless of the antibody panel, move ahead with the therapy. So as the name suggests, autoimmune encephalitis, so we are planning for immune modulatory therapy. And the first line, so you have multiple lines. So you have level 1, level 2, and level 3 medications available depending on the response that you actually follow up in the due course. So the first line therapy would be methylprednisolone. So same dose, 30 milligram per kg, 3 to 5 days is what we actually plan for. And then maintenance with oral steroids. You could also consider use of intravenous immunoglobulins. You could also consider plasma exchange, but plasma exchange is of a constraint primarily because of the extracorporeal volume that may be required for a child, and you may not have the right tubings and set for this. But with the advantages and the advances, maybe plasma exchange would also be available for each and every scenario. Now, what were we looking at? So we're looking at change in the pattern. Now, is the pattern change immediate? So does the medicine actually create an immediate impact? The answer is no. So the question about moving to a second line depends on how long do you need to actually wait before you decide on the second line. So you can wait for 2 weeks, 4 weeks, but by the end of the 2-week period, after completion of the initial methylprednisolone or IV immunoglobulins, if you're not generating an adequate response, you should move to the second line, of which rituximab, cyclophosphamide, as mentioned in the flow chart, will be the next available options. And beyond that, yes, tocilizumab, we are looking at using it higher up. And with the current pandemic situation, probably many people are aware and comfortable with the use of tocilizumab. So you could definitely use that in your armamentarium. But what is you have the 2 phases. So you have the active phase where you're actually using these medications, and then you have the maintenance phase. So the maintenance phase again depends on use of oral steroids or pulses of methylprednisolone or monthly immunoglobulins, intravenous immunoglobulins, depending on the initial response. So by and large, most are maintained on oral steroids. The dilemma is about when do we stop the oral steroids. So you could probably follow them up because recurrences and relapses are known with autoimmune encephalitis. So you plan for minimum of a year or 2. At the same time, not for this case, but slightly older kid, probably looking at malignancy as a, so this being a paraneoplastic presentation. So that is what we should also screen for. So depending on the age, the subsequent investigations during the maintenance phase are also planned. So maintenance therapy, oral steroids would be the long therapy for us.
Thank you, sir. So in our case, the child was given injection methylprednisolone at 30 mg per kg per day for 5 days and IVIG at 2 gram per kg over 2 days. And tapering of oral steroids was done over 6 weeks, and anti-epileptics were continued, levetiracetam, valproate, eptoin, and clobazam. Patient improved over the next 14 days in the form that she had no repeat episodes of seizures, and aggressive episodes had also decreased. Now the child is following with us up on OPD basis, and we are planning to taper AED. So my last question is to Dr. Neeta Nayak, ma'am. What is the outcome of autoimmune encephalitis?
If it is NMDR encephalitis, which is the commonest and around seen in 50% of the cases of autoimmune encephalitis would be NMDR, the outcome is very good. But I think 2 factors will have an effect on deciding what is the outcome. One is how early you treat, and second is whether your treatment is adequate or not. If you leave the treatment after, say, giving only IV and not use tapering steroids, or if the treatment is inadequate, then obviously there can be a relapse. But overall, 80 to 90% of the children do respond very well to steroid. And if the children respond, and if there is a relapse, which may occur in some cases, usually the relapse is monosymptomatic and it is not polysymptomatic. So all in all, especially in NMDR encephalitis, the outcome is reasonably good or very good. And sometimes monosymptomatic relapse which occurs will need again a repeat course of steroids, for which after which the child, and also some amount of anti-epileptic or medication for movement disorder which is the likely, relapse symptomatology, the child should do well in long term.
Thank you, ma'am. So our take-home message is suspect a case of autoimmune encephalitis whenever there is drug-resistant seizures or there is neuropsychiatric manifestation with normal imaging. And treatment should be initiated empirically as soon as the diagnosis is suspected, even prior to antibody test results are received. And early treatment results in better prognosis. Thank you, ma'am, for this wonderful session. Now, the second case will be presented by Dr. Shirsi. Good afternoon, everyone. I'll start the second case. A 2-year-old male child, first by birth order and born of non-consanguineous marriage, was brought to us with complaints of history of delayed milestones and multiple episodes of seizures. The seizure started at age of 4 months, generalized tonic seizure, mostly for 3 to 5 minutes, with post-ictal drowsiness for 10 to 15 minutes, approximately 1 to 2 episodes per month, now controlled on anti-epileptic drugs. His mother gives history of feeding difficulties. However, no investigations were done for the same. On birth history, he was full-term normal vaginal delivery with birth weight of 2.5 kgs. However, the child did not cry at birth and required bag mask ventilation for resuscitation. He was ventilated for 6 days with multiple seizures on day of life 2 and had a total NICU stay for 20 days. Developmentally, he can sit with support at present, showing a developmental quotient of 30%. Fine motor wise, he has immature pincer grasp at present, showing a developmental quotient of 40%. And the language milestone, he can only babble, and social milestone wise, he responds to name. Thereby, he has severe global developmental delay. There is no significant family history in this case. On general examination, he was vitally stable with dentition as per age. There were no neurocutaneous markers or dysmorphism and no contractures. On anthropometry, he had microcephaly with moderately acute malnutrition. On CNS examination, he was conscious and oriented to mother with vision being normal, no apparent squint. Exaggerated gag reflex were present and other cranial nerve examination was normal. On motor examination, tone was increased in bilateral upper and lower limbs, grade 2 on the modified Ashworth scale. Power was more than 3/5 in all 4 limbs with reflexes bilaterally brisk and planters bilaterally upgoing. To summarize our case, it was a 2-year-old male child with history of stage 2 hypoxic ischemic encephalopathy with severe global developmental delay, with epilepsy, with microcephaly, with spastic quadriparesis, with moderate acute malnutrition. My first question goes out to Dr. Mona ma'am. What are the types and early markers of cerebral palsy?
Coming to the types of cerebral palsy, we can have, as textbook teaches us, and it's given well in all the textbooks, that we can divide them into by the topographic classification. And here we can see very nice in this colored pictures is the hemiplegia type. Okay, which one upper limb and lower limb both are involved. You have the diplegia, all 4 limb, but lower limb more than the upper limb. Quadriplegia, all 4 limb, upper limb more than the lower limb. The atheratoid type of CP, the dystonic type of CP, and the ataxic type of CP. Now, depending on the areas of brain damage, again illustrated well in the MRI pictures that we can see here. Again, we can differentiate the type of CP depending on the tone, whether it is spastic, whether it is dyskinetic or ataxic. And we can grade also whether it is a mild involvement, a moderate, or a severe involvement. Can I have the next slide, please? So going on to how does one suspect for cerebral palsy or the early markers of cerebral palsy? As we said, as we've been saying since morning, it's the history which is important, the antenatal history, the postnatal history, and the post-neonatal early period of the child say infancy development, any history particular of infections, etc. And when the baby is born, any abnormal behavior, as we commonly say in our history, whether there's a history of neonatal encephalopathy, and this is usually indicated as irritable child and sleep disturbances may be present and feeding problems, issues, etc. So again, coming to oromotor problem, either there is a poor suck, tongue retraction, continuous grimacing, pressing, poor head control or early head control, hand preference, which has appeared much more earlier than say coming at 1 to 1.5 years of age, abnormal tones. All these are indicators of, and with the background of history and abnormal neurological examination, these are all indicators when one can suspect cerebral palsy.
Thank you, ma'am. The next question is for Dr. Arpita, ma'am. What are the role of investigations in cerebral palsy?
Yes, so role of investigation in cerebral palsy regarding the neuroimaging. Do we really need to do a neuroimaging in each and every case of cerebral palsy? Maybe not, because if there is a defined cause like an hypoxic ischemic encephalopathy, then you need not do a neuroimaging, although in 90% of cases of cerebral palsy, the neuroimaging is abnormal. It is very important to do a neuroimaging in cases where you are considering a CP mimic, where it is not like a CP, the history is with global developmental delay, but there is a family history, there is consanguinity present, and the child is behaving, either he's progressing or he's static. So he's having different signs and symptoms. To rule out a CP mimic, such as, when you're thinking of a diplegic CP, you think of hereditary spastic paraparesis, where you don't need a neuroimaging, but you need a genetic testing. When you're thinking of dyskinetic CP, there are certain metabolic disorders like glutaric aciduria and all, which can go in favor of a dyskinetic CP, which look like a dyskinetic CP, but it's a CP mimic. You would do a neuroimaging to rule out that it is not a CP, but it is a metabolic disorder. So determine the etiology of CP in unknown cause, an MRI needs to be done. Another, you need to do the MRI to know the type, the extent, and possible timing of brain damage. One of the cerebral palsies in which a neuroimaging might help is a hemiplegic cerebral palsy, which can be secondary to a porencephalic cyst. So if there is a huge porencephalic cyst, some intervention could be done if the neuroimaging is done early. It is important for prognostication to give a prognosis to the parent, like what is the child's future and what would be the probability of walking. A neuroimaging can be important. Yes, to determine the functional limitation and to score the child. Identification of any malformations, which is one of the etiologies in cerebral palsy. What is the role of EEG in cerebral palsy? Per se, a child only with cerebral palsy without any seizures, an EEG is not needed, but you need to consider an EEG when a child is coming with epilepsy to rule out any other epilepsy syndrome as well, which can come in a cerebral palsy child. It is very important in a cerebral palsy child who is having seizures, and these seizures are refractory, to rule out non-epileptic events as well. So for that, an EEG and a video EEG can help to differentiate epileptic seizures from non-epileptic paroxysms. And again, an EEG in a child with cerebral palsy who's got a very bad MRI can help for prognostication regarding the brain, like, what is the outcome and what would be the severity of the child.
Thank you, ma'am. The next question is for Dr. Neeta Nayak, ma'am. What is early intervention and when to begin in a case of cerebral palsy?
Early intervention is basically a multidisciplinary therapy approach in a child who has cerebral palsy. Ideally, it should begin as early as possible. And if you know that the child in NICU, also you're expecting that the child has had, or if you know that has a history, the child has brain damage or any kind of brain insult, then there are therapists who start working from the occupation, from the neonatal period, where they actually train the mother about the positioning of the child and how to feed the child, how to hold the child, etc., etc. So early intervention is very important, mainly because from point of view of the neuroplasticity of the brain, because we know that the brain is plastic till 5 years of age, or maybe maximum till 4 years of age. And if you can make in a CP child, the golden rule is if you can make a child sit by the age of 2 years and stand by the age of 4 years, the child is likely to be mobile. So whatever needs to be done early, appropriately, and with parent participation. It is also the early intervention. It is important that the parents are trained and parents are also taught to what to do at home. Simple things like posture and multidisciplinary stimulation, because the child after all is going to learn only when his curiosity is awakened, his sensory issues are tackled. If the child has associated CVI, that is central visual injury, that is looked at. If he has hearing issues, then some speech therapy done. So all integrated, when you do an integrated multidisciplinary rehabilitative approach, I think it will be the most appropriate early intervention. That is the best prevention of cerebral palsy, where already the primary prevention you cannot do, but at least secondary prevention of the worst possible outcome that may happen.
Thank you, ma'am. We'll go to the last question. It's for Dr. Shekhar Patil, sir. What are the CP mimics in this case, and what is the role of a pediatrician in CP?
Okay, so as Arpita has pointed out about the role of MRI, but what is important is to pick up the clinical clues. It is very important to actually not label a child who has CP as cerebral palsy. Probably the best approach is to actually in your first visit put it as a note that probably an evolving cerebral palsy, which means that you are not clear or not really sure about how things are, even though you may have a dedicated story of a birth asphyxia. So the reason here is that you're not missing out on CP mimics. So probably maybe 3 months later, 6 months later, when you have more serial follow-ups and visit, you can understand the progress. Then you can actually know that, okay, I'm not static, I am making some good progress. Then you would say that, yes, the clinical pattern is in favor of a cerebral palsy. Otherwise, you are not making progress, you have some suspicions in the story, the pattern on clinical examination is not very typical, you have evolving symptoms or periods of regression, then I think that is a red flag. And that is the time that you would think of a mimic for cerebral palsy. And here the imaging is of utmost importance, because most of the cerebral palsy mimics will have some abnormality on the imaging. To highlight a few cases, white matter diseases, leukodystrophies have been placed up, metabolic diseases, HSP, so hereditary spastic paraplegia. We had a very good video shown by Dr. Vilas about DYT, where you did have spastic diplegia and a differentiation, what we call as a DOPA responsive dystonia. So you should always be aware of these situations where there is a possible treatment. Arginase deficiency, yes, for short stature, spastic diplegia like presentation, you may pick up on some other clinical cues or probably lab parameters, ammonia, arginine levels, but that should be in a clinical setting of a spastic diplegia. Torch infections always there. So if you have a low birth weight and unexplained jaundice during the neonatal phase as a paraneonate, maybe some degree of visual impairment, early cataract. So these are all clinical cues that may probably point towards something else. So then torch group comes higher up. So then you do MRI scan, but sometimes calcification may be missed. So in such settings, if you're strongly suspecting, you are better off doing a CT scan. But the newer techniques and modalities of imaging, even on the MRI, you can pick up calcification based on certain what we call as SWI sequences. So the sequences may help you in pick up calcification on an MRI, even in a setting of a torch. So that is probably what we would really look at. So keep an open eye, do not shut down and make a diagnosis of CP right at first visit. Follow it up, and then you can probably pick up on all those scenarios palsy, but are not truly cerebral palsy. Then the next point about what would be the role of a pediatrician. Now it is a general trend that, okay, nothing can be done, leave it, just do some therapy and that's about it. So we actually portray a hopeless scenario to the parent, so which should not be the case. There are things that can be done and things that can be modified. So never to lose hope that there can be something that still can be done for this child. And always focus on the quality of life issues. So in this child, we found that in the story itself, there was some feeding issues. So probably we're going to expect swallowing problems, drooling, speech delays. So all because the apparatus is the same. So we probably also are tuned to what to expect in the future, what to tell them, what sort of intervention to be planned. So a malnutrition will be expected. How do I plan the diet? So the role of the pediatrician is most important because that will be the fulcrum or probably the driving force. You would say that maybe the neurologist would be in scenario for cerebral palsy, but I would actually disagree and differ and say that the pediatrician is probably the fulcrum or the center point for where all the other modalities or therapies will be directed towards. So he will be the leading or the driving force. So early intervention. So what Dr. Neeta has actually spoken about, and that is we plan. So you are probably trying to limit the dysfunction that will evolve because you are trying to portray a normal pattern of development before all the. So what we need to understand is that spasticity and dystonia evolve over time. So if you actually stop this by proper positioning and advice, then the dystonic spasms or the trouble spasticity may be less troublesome. I'm not saying that it will not evolve, but they will be less troublesome and probably easier to manage with the amount of medication that you need to put in. So you're looking at treatment for movement disorders, treatment for spasticity. So you have dystonia, which will be a movement disorder spasticity. So you will have always an admixture of movement disorder and tone abnormalities. Very rarely you will find an isolated spasticity. There will be some element of dystonia, some other feature to point towards other movement disorders as well. So kernicterus, very prominent dystonia, very prominent chorea as the child moves ahead. Now, the treatment of comorbidities. Now, that is also equally important. So, looking at you are looking at epilepsy as a marker because your definition also has epilepsy as part. So, you can probably look at these comorbid issues because evolving infantile spasms will again affect the long-term development outcome. So, the overall picture will change once the infantile spasm sets in because that's a very bad epilepsy to have. So, or probably making the parent aware that what is infantile spasm, what to expect, probably demonstrate it to yourself clinically. And if they find any suspicion, to come back at the earliest so that this can be treated early. Goal-directed rehabilitation. Now, this is a term which probably means that you follow the normal pattern of development. At what age you would expect certain changes to come through? What would be your time to use your hands? What would be the time to use your fingers? What would be the time to sit? What would be the time to stand? So you follow the pattern. So the neurodevelopmental therapy will also be always based on this pattern and always make a plan. So what do I expect at this session? So when you follow up, what do I need to understand? So if we are not making any progress, then we go back, revisit. Why are we not making progress? Are the sessions less? Is the therapy being run in a different way? So we have a clinical mind that, okay, this is what I expect, but that has not been conveyed to the therapist, that this is what I expect from you when you actually send the patient back for follow-up. So everyone should be clear as to the goals of rehabilitation. What about the vision? What about the hearing? How do we investigate for possible losses in these functions and what can be done better for rehabilitation? So setting up goals and actually following them up is equally important. Secondary complications will always come up from, again, so here you're looking at a scenario with low weight gain. So low weight gain will always give rise to other complications like repeated infections. Then you also have swallowing difficulties, which means that you'll have pooling of secretion. So again, lot risk for aspirations, recurrent pneumonias. So you have to be aware that this is what else. So if I am at suspecting risk of aspiration, how can I actually move ahead and prevent those aspiration episodes so that I don't end up landing with recurrent admissions to the hospital? And what is most important is what hope do we offer to the family? I think what can be done? So how they should be sure that, yes, I mean, I'm not saying that we are going to make them completely independent, but we are trying to make them independent, trying to make them lead a good quality of life. So let them also enjoy whatever possible way that they can. And probably keep the hope and probably try to work towards it. So long-term prognosis, never let go at first instance that we can't do anything. There are many things that can be done and at least improve the quality of life. So that is the first thing. And always keep the parents in loop. And Actually, sometimes we are more driven by clinical improvement where the parent is looking for something else. So you need to talk to the family. So what exactly at this moment you're looking at? How can I help you better? That is the question that we need to pose to them. And then probably understand their needs, their requirement, what are the social circumstances, financial issues, and how best we can help them. So that is, I would say, a more holistic approach rather than just advising physiotherapy and come back and see me and that's it. So I would say a more prominent role for a pediatrician is there, and everyone should be taking the responsibility for it.
Thank you, sir. That was very informative. I'll conclude with the take-home message, which says that early detection and early intervention of cerebral palsy, along with appropriate rehabilitative measures, will improve outcome. Thank you.
And thank you so much, Shreyashi and Devangana, for the wonderful cases. And thank you all the panelists. Thank you, Dr. Neela.
Thank you, respected panelists, for the wonderful and interesting panel discussion. Thank you so much.
Thank you, everyone, for spending your Sunday with us. And unfortunately, we can't give you lunch. You have to have a virtual.
Bye.
Bye-bye.
Stop sharing. I would like to invite Dr. Mona Gazre ma'am, organizing secretary, to deliver the vote of thanks.
Aditi, and I have a huge list with me for thank yous. I was just discussing with someone that, you know, the online CME has been an eye-opener for us, especially the amount of work. We never realized that there was so much work being done and work is required, and so many support teams, everybody, you know, cooperated so well. So I begin with a thank you to the DAFPAL EC members, especially for concurring with the theme for today of Pearls of Neurology. Also to our patron, Dr. Joshi, Mohan Joshi sir, our Dean of the Institute, who could not be unfortunately present, but decided to do a quick video message for us. Our stalwarts, that Dr. Meenakshi Mehta, Dr. Fernandez, Dr. Lokeshwar, who could not be present, but logged in sincerely and were there with us throughout the program. Our president, Dr. Moralwar, who made it possible to come. He came personally today at 7:45. It was most enthusiastic during the entire program. Our vice president, our president-elect, our immediate past president and ex-HOD, Dr. Manglani, the secretaries, Dr. Nitin Shah sir, etc. And of course, my dear department members, who without whom the CME would not have been possible. We can see pretty Aditi there in the orange dress, and Apurva here with us, who are the MOC teams who did wonderfully well. And Arpita, my co-organizer, has been of immense help. Dr. Neha and Dr. Sadhna from the WhatsApp team, Dr. Sujata, who could not be present today but has worked ceaselessly behind the screen, as to say, Dr. Yashwant sir, my co-colleague at and Dr. Sanjeevani madam for coordinating the whole thing. And I would be, of course, amiss to the head of the ship, of the entire ship, Dr. Radha Gildial madam, who kind of, you know, took the whole thing forward. I remember we had this unannounced announcement that we are going to get 2 weeks vacation. It came suddenly in a rush to us. That was 4 weeks back, and that was the time when we had a department meeting going on. And just a week prior to that, it was decided what would be the DAFPAL dates. So during the vacation, madam really guided us and held the rope steady, so as to so we could function like really well and in a absolutely military kind of fashion. that back to back, everything was done in the right time and the right way under Madam's precise guidance. Thank you, ma'am, for being there and always helping us to our endeavors. And again, since this was an online CME, I-team cannot be forgotten. They were an integral part. We have I-Tech with us who really supported us and were online with us. In fact, they were there with us yesterday also for the drive, though Saturday being their off, Saturday, Sunday being them off. Really hats off to you, I-Tech team, Praveen ji and Shweta ma'am. And our own team, which is headed by Pratik, Harshal, Sagar. They were really the backbone. They stayed back throughout the evenings and working on the slides. And how can I forget Varun, our dear treasurer and lecturer of the department? He really pulled up and he managed to be there with the tech team. And few names again I would like to talk about is Darshan, my CEO, my SMOs and early postgraduates of this institute, Darshan, Raj, Shreya, thanks to you all. And Meenakshi, of course, who holds the entire fort of DAFPAL still together. She's a common thread for so many years for DAFPAL. And not to miss out on Sagar, Ganesh, Bhaskar and Satish. Thank you, everyone. And again, the lead people who supported us were the sponsors. And they would be Sun, who was the first to come in and stepped in, and they really helped us in a big way. Sun Pharma, Hexagon, thanks for sponsoring Madam's oration, Zuventus, Bharat Biotech, MedGenome, and DRL. So thank you, everybody. Thank you. Unfortunately, we cannot share with you our lunch, etc. But next time, maybe we will definitely have an offline CME, and we hope to see everyone in person there. Thank you. Over to you, Aditi.
Thank you, ma'am. Thank you, everyone, all the delegates for attending this CME on a Sunday in large numbers and making this first virtual DAFPAL CME a great success. Thank you again and have a great day.